Good morning, everybody. We're just going to get started. Thank you for joining us for our fourth annual World Bipolar Day Research Symposium. My name is Ben Goldstein, and I'm the director of the Center for Youth Bipolar Disorder here at CAMH. We've been having evening public and family education events for a dozen years now, but this has been more of a new project as bringing together researchers with shared interests in bipolar disorder, in youth mental health, and in brain-body connections. We have some great keynotes today, but I want to start off before moving forward with a land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Ojibwe people of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Ojibwe people of the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich the city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. So it's a great pleasure to introduce for a moment Dr. Benoit Mulsant. Dr. Mulsant, who's going to give us introductory comments on behalf of the University of Toronto Department of Psychiatry, where he serves as Labatt Family Chair of the department, as well as Labatt Family Chair in Biology of Depression in Late Life Adults. He's a professor at the University of Toronto and an adjunct professor at the University of Pittsburgh. Dr. Mulsant is a Distinguished Life Fellow of the American Psychiatric Association and of the American Association for Geriatric Psychiatry, has been listed in the Best Doctors in America and Best Doctors in Canada. Over the past 30 years, he has secured over $100 million in funding, no small feat, including $32 million as $73 million as principal investigator. So needless to say, he's an international leader in the study, in particular of mood disorders and degenerative diseases in the elderly, but has also been a mentor for dozens and dozens of early career investigators, myself included, and is a proponent of lifespan research in bipolar disorder, and indeed is one of the co-investigators on a lifespan project that you'll hear more about later today. Without further ado, Benoit.
Thank you, Ben, for those kind words. And I'm going to use the comment that were prepared by Dr. Goldstein and his team. People usually cringe or are scared when I go off script. So I don't know yet if I'm going to go off script and tell you what I really think, but I'm stepping down from my role as chair of the Labatt Family Chair of the Department of Psychiatry in the next few months, and then come back and I will tell you what I really think. But anyway, here's the script. Welcome all to the Center for Youth Bipolar Disorder, CYBD, 4th Annual World Bipolar Day Research Symposium. There is an ongoing disparity between the amount of research on bipolar disorder compared to other serious mental illness, such as schizophrenia or major depressive disorder. And gaps in knowledge are much greater for youth bipolar disorder as compared to adult bipolar disorder. So then I'm going to go off script and tell you what I said to Ben. It is true that Ben and his team feel that there's not enough research in bipolar disorder and not enough funding, and even less so for youth. So that's true. However, I don't think it's useful in the world to blame the world. You just get up in the morning and you work more and you solve that problem. So maybe that's because there are not enough investigators, and maybe that's because the investigators don't submit enough grants. So don't feel you have a chip on your shoulder and you're disadvantaged. Just say, you're given lemon, make lemonade. So if there is not enough people doing research on bipolar disorder, don't view that as a put down, view that as an opportunity. Anyway, the CYBD it's one of the places that there is research on youth bipolar disorder, and I'm going back on the script, one of the world's leading clinical research team focused on youth bipolar disorder, although bipolar disorder is the fourth leading cause of disability among youth worldwide, bipolar disorder in youth remains greatly under-researched. As such, the productivity and discovery of the CYBD team play a crucial role in advancing knowledge and optimizing treatment of youth bipolar disorder. So today, for instance, is a World Bipolar Disorder Day, and Dr. Goldstein told me the only event related to this day happening in Canada, allegedly, is here in this room. So it is great, going back on script, it is great to see attendees from across Toronto, Canada, and internationally coming together for the purpose of sharing findings and exchanging ideas regarding bipolar disorder, youth mental health, and connection between physical and mental health. This year's theme is Patient and Family Engagement in Bipolar Disorder Research, Lesson from the Past and Building Momentum for the Future. It is great to see this topic featured, and I'm hopeful that collaboration between researchers, clinicians, and people with lived experience will help to accelerate progress and increase impact. I'm sorry I cannot stay with you in this room for the rest of the day. I had some other events that are scheduled not by me, and I cannot not go, and I wish all of you a very enjoyable and inspiring days. Thank you very much.
Thank you, Dr. Mulsant, for the on-script and off-script comments. I think that we all have a bit of a chip on our shoulder, which is that we see a disparity, and we're trying to address the disparity. I think that everybody that's here in the room today is part of an interest, has an interest in an aspect of that, which is whether it's youth mental health, physical health implications, or bipolar disorder. So we're grateful to have everybody here, but perhaps most so for our Youth Advisory Council members. So I just want to acknowledge that we have a Youth Advisory Council, and they've been working with us over the past 3 years, 4 years actually. And this is the first year in which we have substantive participation from them. So if you see them during the day, please introduce yourself, share your interests. And I'm going to call up Sunny from the Youth Advisory Council to share also welcoming comments on behalf of people's lived experience. So Sunny, come on up.
Good morning and welcome to the annual World Bipolar Day Research Symposium hosted by Center of Youth Bipolar Disorder. My name is Sunny Jamieson and I'm a first-term youth advisor and a patient with CYBD. So I've been with CYBD for about 4 years. I started receiving treatment back in 2021 and I'm still receiving said treatment. So my experience as a youth living with bipolar disorder receiving care here has been nothing short of excellent. This level of care and compassion within and outside treatment is something that I've never experienced anywhere else. CYBD has been exceptional with assisting me to navigate this disorder and all that it brings. So these treatments are backed by extensive research that hopefully one day I will fully understand. So research like the presentations you will hear about today are crucial in order to properly educate and help individuals living with bipolar disorder. So as someone living with this disorder, I can tell you that without this vital research, new and old, I wouldn't be anywhere near the person that I am today. This research helps us with lived experience to continue to live and grow as individuals and navigate the complexities that bipolar disorder brings. As we all know, research is the backbone of all the treatments for bipolar disorder. And I can personally attest that this integral and usually unappreciated information and research is necessary for the furthering of treatment and quality of life for those with disorder and their families. So my own experience with research has really shown me what goes on in order to collect and interpret this vital information. So personally, I am one of the youth advisors for the Youth Advisory Council here at CYBD. So this council was created back in 2021 and is composed of 6 youth receiving treatment from CYBD. So I've been a member of the YAC since July 2023, And in this term, we have focused on translating research in order to make it both easier to digest and more accessible for patients and families. So currently, we have filmed 4 interviews, 2 video and 2 audio, where we interviewed 4 researchers about research projects that they have conducted. So working with my fellow youth advisors and CYBD team has been nothing short of extraordinary. It was so amazing to be able to work with other individuals with bipolar disorder to help assist with making these important bodies of work more digestible and to highlight the research and researchers as a whole. So these interviews turned out to be amazing, and they really did help to strengthen the bridge between people with lived experience and the research itself. This connection helps to personify all the amazing work that you all do to better understand this misunderstood disorder. So being able to interpret this information and make it more digestible for individuals like myself outside the scientific community is something that has been a great honor to conduct, as well as something that is truly necessary to destigmatize bipolar disorder and humanize the research. I hope that we can continue to help change the world one study at a time. So thank you so much for this honor. I am eternally grateful that I get to be here with some of the leading researchers on youth bipolar disorder in the world and the rest of the scientific community. Thank you, and Miklowitz.
Thank you so much, Sunny. Inspiring as always. And for those who missed Sunny's presentation 2 years ago on the evening of World Bipolar Day, you can check it out on our website and as it's stored there. So this brings us to our first keynote speaker, who's Dr. David Miklowitz, who I've known, we figured yesterday, for 19 years. He's an international leader in the study of bipolar disorder in adults, having established family-focused therapy as a leading option, and then moving towards youth bipolar disorder and youth at risk for bipolar disorder. Dr. Miklowitz is a distinguished professor of psychiatry and director of the Child and Adolescent Mood Disorders program at UCLA. His research has helped establish the effectiveness of family therapy and other psychosocial interventions as adjuncts to medications in the treatment of bipolar disorder. His work has been recognized with the Mogen-Schow Award from the International Society for Bipolar Disorders, the Clerman Senior Investigator Award from the Depressive and Bipolar Disorder Support Alliance, the Bipolar Mood Disorder Research Award from the Brain and Behavior Research Foundation, and a Distinguished Scientist Award from the Society of Science of Clinical Psychology. He's one of only 3 psychologists to have been awarded this prize. He's received continuous funding from NIMH over the past 35 years, has published 400 research papers and 8 books. For those who haven't read them, these are very widely read and very practical books on living with bipolar disorder, including the Bipolar Disorder Survival Guide, which has sold 350,000 copies in print, which is really remarkable, as well as Living Well with Bipolar Disorder. Dr. Miklowitz, thank you so much for coming. We look forward to your presentation. Yeah, it should. Yeah.
Okay. Morning, everybody. Before I get started, when I start talking, I tend to start speeding up and then my voice gets lower and lower and lower. So I'm going to ask somebody in the back row if I start getting inaudible to just do something like this, and you can do it. Only don't use your middle finger, please. Okay. So I'm very pleased to be here. And thanks to Ben and his team for putting this together. What I've been asked to talk about is engaging and treating families where there's a bipolar member. And I want to kind of give you a background of how this work started and then tell you a little bit about our most recent work. Just a quick couple of disclosures. I have funding from NIMH, from the Bazooki Research Foundation, from the Milken Foundation, Max Gray Fund, and a few others. None of which I'm not going to be talking about any drugs today. the first question I want to ask is, what do we mean by being at risk for bipolar disorder? We all know what the symptoms of bipolar disorder are, about mania and depression, and how this hits sometimes in late adolescence or early, sometimes even late childhood. But what do we mean when we think somebody is going to develop it? Now, I want to get that out first, because a lot of what I'm going to talk about is about at-risk populations. One is having a family history of bipolar disorder, a first or second degree relative, having what we now call BD unspecified in the DSM, which is a sub-threshold version of bipolar disorder. So short manic episodes, shorter depressed episodes, maybe they only last a couple of days, maybe their symptoms short, but nevertheless, we're seeing cycling patterns, mood instability, depression, even from a very early age. And also, these mood changes need to be a change from baseline. We can't just be talking about kids who are chronically moody. We need to see an up and down movement. This type of phenotype is associated with, and of course, Ben and his group at Pittsburgh did a lot of this work. This phenotype is associated with about a 50% onset rate of bipolar disorder within 5 years. So that's what we mean by high risk. Now, the main questions I want to talk about is, first, is there any evidence that family intervention is a useful adjunct to medications? Because we usually talk about treatment of bipolar disorder as being medications. What strategies are effective in working with families? How do we engage them? And do we have any evidence that family intervention is helpful for these high-risk early onset kids? Family-focused therapy, or FFT as we call it, is about 12 sessions long. The acronym we use, like I said, is FFT. I've gotten in a little trouble in the past for using FFT because there's also a therapy called functional family therapy. And in fact, when we started this work, I got a not too friendly email from the makers of functional family therapy for using their acronym. I looked up the acronym FFT, and the first things that came up were Fast Fournier Transforms, the French Federation of Tennis, and Britney Spears' Femme Fatale Tour. So whatever, we're using the acronym. We're way down the list. But nevertheless, we see patients for 12 sessions. We start with an assessment and engagement phase, which I'll talk about. By family, I usually mean a patient with their mom and dad, or if it's an older a patient with a spouse, sometimes with a sibling, whoever they consider to be in a caregiving role as an individual. The first phase is really psychoeducation. And reflect on that term for a minute, psychoeducation. It's more than just education. It's also explaining the disorder in the individual with lived experiences, what did they go through in manic depressive episodes? How should their parents know if they're getting ill again? How should they know if they're depressed? And what should parents do? What should family members do? What can the individual do? What can the doctor do? These are the sorts of things we talk about in psychoeducation. Later, we move on to communication enhancement and problem solving. And these are fairly well-known strategies in the family therapy literature, getting people to talk to each other when there's a criticism, to be very specific about what you mean or what behavior you'd like to see changed, learning to listen, to validate, to give positive as well as negative feedback, to solve problems that come up in family life. And this involves a lot of role-playing, rehearsal in between sessions, and a very goal-directed approach. This is I don't know how well you can see this, but this is a developmental timeline of this work. Really started in the late 70s. I was an early graduate student, and there was quite a bit of this work going on with families of schizophrenic patients by Ian Falloon and Associates, who found that a treatment like FFT was useful in preventing psychotic recurrences in patients with schizophrenia. Also around the early phase was some work on expressed emotion, which I'll talk about in a moment, and in both adults and youth with bipolar disorder. We did our first randomized study of FFT at UCLA in 2003. All along, We consulted with people with lived experience about the treatment, about what we should cover, about how we should talk about it, about the role of the person with the disorder in the treatment. We didn't want to just educate parents. We wanted the patient to be an active participant. We moved into working with adolescents, and that's when I met Ben and his colleagues at Pittsburgh in 2003 till almost 2017. The STEP-BD trial occurred in 2010, up till 2010, which was a comparison of psychotherapies. And more recently, we worked with kids who are at risk for psychosis and bipolar disorder, as I mentioned. We're starting to get in the area of digital applications, which I'll be happy to talk about if there's time. The leading finding that led to this research was a very simple one. If you interview parents of a person who's currently manic, and you make a tape recording of the interview and ask them, how did the illness develop and so forth, you can classify families as high or low in expressed emotion. And by expressed emotion, I mean how critical, hostile, overprotective, problems with boundaries, conflicts. These very high intensity families is what we call high expressed emotion. Low expressed emotion doesn't necessarily mean nice. It means more benign, less conflictual, willing to walk away, willing to end conflicts before they start. And this finding was simply that the number of recurrence, the chances of having a recurrence were much higher in families with these high intensity interactions. And sometimes you could look at these interactions and say, that could go better if people communicated in more direct or more empathic ways, which is what really led to the development of FFT. I'm skating over a lot of the subtleties here, but that was the basic first finding. This slide is what I like to call my career slide because I first developed it when I was going up for tenure at the University of Colorado. One of my colleagues challenged me, can you summarize your whole career in one slide? And his was on rats and whiskers and what the whisker barrel cortex did or something. So he had an easier time than I did. But what I ended up doing was putting together the trials that we've done, the clinical trials. These have all been FFT between 4 and 9 months long versus some kind of brief psychoeducation or individual therapy with medications. That's our basic design. We've done trials in adults, adolescents, kids at risk, adolescents at risk for psychosis, and one on teen offspring of parents with depression or bipolar disorder. We've had over 1,100 patients in these studies, and very consistently, we find that patients in FFT have had greater benefits than those in these brief psychoeducation conditions or individual therapy in depression, recurrence risk, and quality of life. And that we don't always find the same thing in every study. Sometimes it's recurrence risk, sometimes it's depression stabilization, but it consistently comes up. And when we did a meta-analysis on the psychotherapy literature, first we found that psychoeducation was certainly better than supportive therapy in these, whether it was done individually or by family, but working in a group or family format was more effective than working individually. And you can kind of see why. If you're teaching someone about the disorder, you need to have advocates around. So when that person gets ill, other people can help them get access to treatment, whether it be people in a group or a setting like a youth council or a family. That's what we think is really effective when you're doing psychoeducation. Now, what do we do in this treatment? Well, first, we have to engage people. So we have somebody who's coming off of a manic or a depressive episode. They might be 15, they might be 25, they might be 50. Get the person's buy-in. By the way, what I call a young person has changed over time. I used to say it's somebody under 30, and now I'm saying it's somebody under 50. Get a person's buy-in. Could having your family here help you? We use a very Socratic approach to therapy, meaning you ask questions. What's your experience with this? I don't teach. I ask, what is mania to you? What is depression to you? What does it feel like? We encourage everybody to pitch in, and even the people who don't want to talk. We tell the person with the disorder, you're the expert here in this illness. You've been through it. So explain to us what it's like. What stresses you out? How do you know you're going into a manic or a depressive phase? Sometimes you get very strong affective reactions when you start working like this from family members or from patients. You deal directly with those, all the while recognizing the person's need for autonomy. This is not like taking care of a very sick person. They need to feel like they have agency over their choices, whether they're medication, diet, psychotherapy, hospitalization, and so forth. So those are some of the strategies. Our psychoeducation runs on average about 4 sessions where we talk about the signs and symptoms of the disorder, about mood charting, stressors, and we end up with a prevention action plan, which I'll describe in a minute. One of the things that I learned very early on from people with lived experience when we've run groups, for example, of people with lived experience. What do you want in something like a family therapy? Well, one of the things they say is, don't just feed us information. It's not enough to just go on a website and find out, hey, I've got to keep my sleep-wake cycle regulated, or I've got to eat better diets, or I've got to take my medications. I want to know how this is relevant to me. And so we are thinking now about psychoeducation as being first giving people information. Did you know that bipolar disorder people are very sensitive to changes in sleep-wake cycles? That's an example. But how does that relate to you? Maybe the person says, well, the last 2 manic episodes I had came after when my sleep got way off. All right. What do you want to do about that? Do you want to try to regulate your sleep-wake cycle? How might you do that? This motivational enhancement comes into this, not just sort of telling people this is what you should do, but how does this apply to you? How could you imagine your family helping you with sleep-wake cycles or taking medications or diet or whatever we're talking about? So it's really a couple of different levels of information. We might hand a kid, let's imagine for a minute they're 13 years old. We hand them this handout and say, which of these symptoms do you remember having when you're manic or having now? Can you tell us about them? Can you tell us what it feels like to be decreased need for sleep or to have increased activity? Then we ask parents to chime in. What do you experience when he is going or she is going through these stages or these states? What does it feel like to be overconfident, or how about being irritable? Can you explain that to us? And we also ask our clients to keep track of their mood in the form of a mood chart. Interestingly, this particular mood chart was developed by a 13-year-old girl who wasn't interested in the ones we had, which had boxes and arrows and kind of looked like a tax form or something. So we asked her to make her own. She was artistically inclined. This is what she came up with. She described her moods as angry, down, balanced, energized, or super hyper. She kept track of her moods over a course of a week and her sleep-wake cycles. You can see there's quite a bit of variability in mood. That doesn't mean that she is manic or depressed during this week, but she certainly had some mood fluctuations. Then you can get a family involved in what are the triggers of these mood fluctuations? How does medication play a role? Why is sleep irregular? What happens? How do these things get triggered? 1 week is never enough. You have to do this sort of thing over many weeks. The other thing we do is called a prevention action plan, where you encourage the family to think about the most recent episode. And let's say there was a manic episode. What were the stressors, if any? This particular patient said arguments with my dad was a stressor and getting fired from my job. Of course, we don't know if that was actually a cause. It might have been that he was getting manic and then he got fired. But nevertheless, he lists that as being a trigger. What were early warning signs the family picked up? Well, of course, decreased need for sleep, being irritable, being easily annoyed, being obsessed with video games was something he brought up, talking loudly about ways to make money. His mom brought that up as a prodromal sign. What can we do as a family? What are the coping skills? Well, get a medication check, try to keep a regular bedtime, reduce use of iPhone between 11 and 7 in the morning. And as he put it, stay away from friends who make me want to smoke weed. What are the obstacles? You can put together a plan like this, and then hopefully the next time there's prodromal symptoms, they have a set of strategies that they can go to. You often have to modify this over time because no two episodes are exactly alike, but you begin to see some themes and some things that do and don't work. Later on, we go into what we call our communication enhancement phase, in which we really focus on how do people talk to each other in the family, particularly if they're living together. How do things get done? How does the family cooperate in doing its daily tasks? We teach 5 skills: expressing positive feelings, active listening, making positive requests for change, communication clarity, and expressing negative feelings. All of these are accompanied by handouts. Active listening, for example, nod your head, paraphrase, all the things we do as good therapists. Only do that in your conversations with your family members, or stick with one topic. Don't jump from topic to topic. Or if you make a change, ask for a change, make it very specific. This is one way we try to deal with excessive criticisms. Remember the high expressed emotion construct I mentioned earlier on. And let me give you an example of how one of these sessions goes. So in this example, and this is a real family we worked with, a father, a mother, and a 16-year-old boy with bipolar 1. And he also had suicidal ideation. We asked them to talk about a family problem. And Dad said, "Son, I really resent the hours you keep. You always come in later than we've agreed on. You're loud, you wake us all up. It makes me think you don't take your illness seriously." Now, notice that's at first it's a criticism, but it's also an attribution. It's a causal attribution. You are doing this on purpose. You're doing this because you're inconsiderate, which is one of the things people with bipolar disorder hear often is you're doing this to hurt us. It's not an illness. You're just being mean, which we don't believe, of course. Son does the one size fits all, responsive teenagers, whatever. Father says, you have to choose to get to sleep on time so you don't go wacko again. So again, it's you're choosing to be ill is the concept here. What do we do with this? So the therapist comes in. First thing he has to do is validate Dad, because Dad is angry, clearly. Dad, I can see it upsets you when Evan comes in late, wakes everyone up. You're angry, but you're also concerned about his health and well-being. Dad looks with pride and said, of course. But consider how you're delivering that message. You care, you don't want him to get hurt, but I'm guessing he's only hearing your anger. So then we check in with Evan. Evan says, that's all I ever hear from him, one criticism after another. No matter what I do, he's always pissed off. So the therapist says, Dad, I wonder if you'd be more effective in getting your point across if you said it in a more positive way. Now here's where we get into communication skills. We might give him a handout like this. Can you say it this way? Can you say exactly what you'd like him to do differently? Tell him how it would make you feel. Use statements like, I'd appreciate it if you would. It's important to me that, rather than this sort of angry, critical, negative attribution. So Dad tries. First thing he says is, okay, Evan, I'd appreciate it if you would come home earlier, or at least let us know if you're held up somehow. That would make me feel like you weren't just blowing me off. The therapist says, good start. Evan, what did you think of what Dad just said? Evan says, the first part was okay, but was that what he was supposed to do at the end? Therapist says, can you try again? Only this time add something at the end about how that would make you feel, Dad. Dad tries again. Okay, Evan, I'd appreciate it if you would come home earlier or let us know if you're held up. Text me or something. That would make me feel like I'm being respected. Therapist says, better. Evan, what did you think about how Dad just said that? He said it better, but I don't know if I'll be able to do it. Dad suddenly changes gears and says, you'll do it if you want to keep using the car. Now, therapist has a choice point here. They could get into a whole problem-solving discussion about use of the car, but he doesn't. The therapist in this case says, Dad, nice job with that request. Let's talk about how you might practice some of these skills at home, about how you might turn criticisms into requests. That doesn't mean everything you ask is going to be fulfilled immediately, but certainly it's going to create a more collaborative environment. And that's what we're trying to do, is create a more collaborative discussion where the person can thrive, but the family members don't feel as burdened. Finally, we move on to a final phase, which is solving problems. It seems very concrete, talking about family problems like getting the house clean or taking care of children or getting the food cooked or the shopping done. But some of these same behaviors really go underground when someone goes into a depressive episode in particular. They may have to relearn some of these skills. So we go take the family through a discussion about problem solving. How would you solve this? What is reasonable for her to do right now, given that she's depressed? How do we get her activated in the depressive phase? That's the sort of thing that comes up in problem solving. Now, what are we finding? Let me get more specific about what we're finding in kids at risk. And again, we're talking about kids who are between the ages of 9 and 17 and have early warning signs of bipolar disorder. They're not bipolar yet, but there's the family history and there's the early warning signs. We've done two studies so far, randomized trials. The first was when I was at University of Colorado, was a collaboration with Stanford. We had 40 kids. They were on average 12 years old, 20 at each site. Some of them had bipolar, not otherwise specified. We also took kids with major depression who had a family history of bipolar disorder, since that's also a risk factor. We randomized to two conditions. The enhanced care was basically whatever medications they needed, plus a little bit of family education, not the full FFT. So they only had 2 additional sessions from us versus 12 in the FFT condition. And the finding was pretty straightforward. We looked at time to recovery. The red line there is the enhanced care comparator. The yellow dots are the family-focused therapy. You can see that many more people, not many more, but more people recovered in the FFT condition in the 52-week follow-up. And on average, they recovered around 13 weeks versus about 23 weeks, 22 weeks in the comparison condition. But what was interesting for me was this little finding at the bottom right. The effects were stronger in high conflict families. That's where we really saw quicker recovery of the individuals, partly because there's more to work on. There's the communication, the conflict is a regular part of family life. And so it may be that the high conflict families are those who are we should be targeting or offering this to first if we have a choice. Oops, going up instead of down. We just finished, well, been 5 years now, 4 years now. We finished a trial on with 3 sites in it, which was Colorado, Stanford, and UCLA. We had 127 kids, on average 13 years old. They had either major depression again or unspecified bipolar disorder. They entered with depressive or hypomanic symptoms. Actually, most of them were not taking medications. Some of them were on about a quarter were on mood stabilizers. Some were on antidepressants, some were on psychostimulants, but generally it was a less medicated sample. We compared 12 FFT sessions with a little bit more souped up comparison of 6 sessions of family and individual psychoeducation. They both lasted 4 months with pharmacological treatment and follow-up over an average of 98 weeks. Here's the main finding. Once again, this is a time to recurrence, how much time passes until the next episode. And in that case, you want the FFT group to be on top. The other one was recovery. This is time to episode. You could see here that the next episode occurred later in the family-focused therapy condition versus the comparator by an average of about 18, 17 weeks. So basically, we're keeping people well longer. And particularly for depressive episodes, delaying the next depressive episode was our primary finding. So we're not whoppingly changing the course of the disorder, but this is kind of like the effects you see with medications. You cut relapse rates by about 30%. So this is a reason to combine family treatment with medications. We also saw an effect on suicidality. We defined suicidality broadly as either sudden increases in suicidal ideation, hospital visits for self-harm or for suicide attempts, self-cutting. We saw a rate of 24% in enhanced care and 13.6% in FFT. When we looked especially at self-harm with explicit suicidal intent, we saw only 10 kids in that category. And I think that says one thing is that being in these long-term trials is useful in itself. 8 of those 10 were in the control condition, 2 in FFT. So there's some hint here of delaying or preventing suicidality as well from having the family involved. I want to just end by talking a little bit about our network that Dr. Goldstein is involved in and several other people are involved with, as well as the funding from the Bazooki Research Fund and earlier the Milken Foundation. This is an attempt to bring together universities who are interested in child and adolescent onset bipolar disorder or high-risk conditions. We have our coordinating site at UCLA, but we also involve Pittsburgh and Colorado and Cincinnati, very collaborative work, and we all have specialty clinics in bipolar disorder. We have a number of aims. I won't go through all of them, but among other things, we're interested in, do we treat kids the same way at different sites? Do we use the same medications? Do we use the same psychotherapies? Do we get the same outcomes? We are interested in a construct called mood instability. How much change is there in mood between episodes? Because we know that in itself is a predictor of how well or not so well people do and have a lot of fluctuations. We're examining food intake, dysregulation of glucose, insulin resistance, neuroinflammation. And most recently, we've started through the Bazooki Foundation, we've started a foresight trial of ketogenic therapies, just getting started recruiting our first subject for that at these different 4 sites. It'll be a 16-week trial. We've, in the course of doing CABIN, as it's called, how much time do I have? Okay, okay, good. In the course of doing CABIN, we really got a lot of input from people with lived experience. For example, parents would tell us, these mood charts you could send us, they don't really grab what we're seeing. You talk about it in terms of mania and depression, but we're seeing ADHD and anxiety and up and down, some psychotic thinking. Is there something you can send us that's more tapped into what we're seeing on a day-to-day basis? And the kids were saying, you asked me to make 1 mood rating in a day, but my mood changes 20 times in a day. So what am I supposed to do? Make 20 ratings? Is there something else you can send me? So we gave that a lot of thought. We came up with 2 things. This is something Bob Post, a leader in our field, developed. We call it the POWERS, the Parents Online Weekly Evaluation and Rating of Symptoms. And basically what parents do is they get a text message with a questionnaire and they rate for any given week how manic, how depressed, how ADHD, if it's present, how anxious, if there's any psychotic symptoms, or if there's any oppositionality. And you can get a sense over weeks of the course of the illness, as well as, if you look at the top, what medications might be doing. In this case, I think can't really see it from here, but I think there was a medication change about 1/3 of the way in, and you could see somewhat more stabilization after that. But one of the things we're learning from, this is just one person, but one of the things we're learning from this is that parents don't necessarily think in terms of mania and depression. They see behavior, they see oppositionality, they see not doing homework, they see not going to sleep, not being part of the family, isolation. And that's what they're interested in rating, not the clinical syndrome. They don't get angry and say, I'm really pissed off that you have elated mood. You don't hear things like that. You hear things like, you're being disrespectful, you're being irritable, you won't get up on time for school, you won't go to school, you won't do things that you need to do. And that's really what we want to tap into. For the kids, we decided to go into the area of ecological momentary assessments. And what that is a fancy term for texting them every few hours and asking them to make a mood rating. We struggled with how do you make a mood rating every 3 hours? So what we did is come up with some standardized words like happy, mad, sad, joyful. This is one kid over time. This is a 6-day period. I think there were 30 sub ratings. The child sent back was a girl with bipolar 2. And you can see there's quite a bit of variability even in one day. And needless to say, being happy and mad and sad at the same time, even separated only by a few hours. We might call that mixed symptoms. It might also just be the natural course of mood instability in these kids. Of course, we don't know what a teenager without bipolar disorder, where we'd see the same up and down movement, but I suspect it would be less severe. So that's one way we can look at mood instability over time. Interestingly, we're also finding a connection between insulin levels and how the kid rates the symptoms. If they rate their mania symptoms as up and down a lot during the course of a week or 2 weeks, we are finding that their insulin levels are higher, which is very much consistent with the metabolic theories of bipolar disorder. Ben, of course, has done work in this. The Bazooki Foundation is very interested in this. Insulin resistance affects 52% of adults with bipolar disorder. We know there are severe problems with weight. Sometimes that's due to the medication, sometimes it's due to the illness. And we can see these changes in insulin, which of course allows glucose to be used as a source of energy, but then it becomes less effective as more glucose is produced, more insulin is produced. And as we see these biological changes, we also see more mood instability. So it's findings like this that fuel our interest in ketogenic diets. This is our ketogenic diet. And by the way, this is usually part of the talk when I start doing pressure of speech and sounding more and more hypomanic all the time. But basically, we're looking to enroll some 60 kids at 4 different sites in this child bipolar network, cabin as we call it. We're looking for kids who are depressed or have bipolar unspecified or bipolar 1 or 2. We're doing a fairly extensive evaluation of their background pharmacologically, metabolically. We test their executive functioning. We work with the family to explain what the diet is all about. A ketogenic diet, as you may know, is very low carbohydrates, high in fats, and medium in proteins. And the idea being that very high carbs is what's fueling this glucose insulin cascade that we think may be dangerous for kids, even if they're not even if they don't have diabetes or a similar metabolic dysfunction. We are going to initiate the diet slowly for a couple of weeks, and then they'll stay on our pharmacotherapy, and we're going to actually deliver the food, the keto food, to the kids in the form of a meal delivery service so that they can stick with these proportions of low carb, high fat, medium protein diets. And we'll see over 16 weeks, first, do kids actually stick with a diet like this? Are they willing to test their ketones on a daily basis with a finger prick? Does the family get on board? Do they show improvement in mood over a short period of time? Does their depression get better? Do they feel more physically active? And is their attention, their executive functioning improved? This is, of course, not a randomized trial, not yet, but it will be. If we find positive benefits, then we'd want to compare it to either another diet or diet as usual. So that's one direction we're taking in this work. So this is, I want to give this website just because the handouts and the clinician's manual and all that is online. If you want to learn how to do this treatment, just go to this site and you'll be able to download a clinician's manual with all the handouts and, what do you do in the first session, the second session, and all that. We make that open source. And that's also our clinic where we see kids with depression and bipolar disorder. It's a training clinic for psychologists and psychiatrists at UCLA. And I can't leave without a bit of shameless self-advertising. This is our new book on bipolar disorder. It's called Living Well with Bipolar Disorder, kind of the practical strategies you could do on a daily basis to manage your mood. So I'm going to stop there and take some questions. Thank you very much.
Questions from the audience and then online as well.
Yes. You might have to talk loud.
Hi, question over here. Thank you. Beautiful presentation. I'm wondering if you can give some insight into how your therapy approach is having temporary or longer term changes to the brain, and thinking about the emotional circuits in the brain. Can you kind of put it in the context of like one session, almost like what exercise does to your body? What does the family therapy session do to the brain?
We have one neuroimaging study on FFT where we did an fMRI assessment before therapy and an fMRI assessment after therapy. It was a facial emotion recognition task. And we saw a basically decrease in amygdala activity, an increase in dorsolateral prefrontal cortex activity, but only over 4 months. So in this task, but it was specific to the FFT condition. The question about how long does this last? We've only followed people for 2 to 3 years. I don't know if if after 5 years they still remember things they did, or if their family relationships are better. I would love to do a study like that. It's very hard to follow people that long. A lot of these kids go off to college, and we hear things like, "Hey, they're doing great. They're in college. Or, the medications aren't even taking that much medication now." About 25-30% of them look well at 3-year follow-up. But we don't know that that's due to the family therapy or if that's just the natural course of the illness. So it's a good question. Yes, over here.
Hello, thank you. Excuse me. That was a great presentation, by the way. The question that I have is, I didn't see the medication side of the treatment versus FFT, and how, if your patients within the study were taking medication. And one personal question I have to follow up is, if the patient is not taking medication, how does FFT help?
Good question. So the way we design these studies is everybody gets medication, and the physicians who are part of the study follow a medication protocol. So they follow the same rules when they're adding a second agent, or if they're adding an anti-anxiety agent. So we try to keep that controlled and try to keep the physicians blind to the therapy condition. It's not always possible, but we do our best to try to do that. We've not found interactions between being an FFT and specific medication regimens. We've never done a study of medication only versus FFT only because we don't think it's not ethical at this point to just do therapy with most people with bipolar disorder unless they have a very mild form of it. So we can say that it doesn't appear that the effects are due to differences in medications between the two treatment groups. But I think there's an effect that's due to medication. There's an effect that's due to psychotherapy. That's the way I would put it. About what do you do in families when they're, interestingly, one of our first studies on FFT, we found an effect of therapy on medication adherence, that when the family was involved and they were educated about the illness, people were more likely to take their medications. At that time, it was lithium and carbamazepine. It was a long time ago. So I think there is some advantage in having the family in terms of compliance, partly because you talk about what are the purposes of the medications. The side effects are real. They're not just complaining. This is important in terms of preventing recurrences. Developing a relationship with your physician is important. A lot of times families will ask us, why is she on this medication versus this one? We might bring in the psychiatrist to answer those questions. So it's very much a part of the therapy. They're not separated.
Thank you.
Time for maybe one more question.
One more? Yeah. I'm sorry.
Thank you. Because of the age group, is there anything about hormonal influence on the disease progression? And then as they get older, what that might be as they age out?
Mm-hmm. Yeah, that's a very interesting question about hormonal influences. I can tell you in the broader literature, this is not our studies, but the broader literature, boys and girls are equally likely to be depressed before age 12. After age 12, it's 3 times as common in girls as in boys. And we think that must have a lot to do with hormonal changes, but it's probably also due to body image stuff and peer pressures and all the things that go along with being a teenager. Nobody has found a specific hormonal abnormality that explains bipolar disorder. It's not like it's due to too much testosterone or estrogen or thyroid or something like that. But sometimes we do find endocrine abnormalities that require specialist care, like a thyroid supplement. Low thyroid tends to show up later in a lot of these folks, especially as women go through menopause, for example. You sometimes see low thyroid levels, and you have to treat those separately. The therapies, I don't think, are really aimed at that part of the equation.
Just thought it would be interesting just to see the graphs.
Yeah, of onset. What we don't know is whether that's true for mania too, whether mania goes up comparably. So anyway, I'm out of time, so thank you very much.
Thanks so much, David, for that great overview. I mean, to see a slide that starts at 1978 and it's still going and advancing and broadening is just, I think, really inspirational. So we're going to shift to our next speaker. We have the great fortune that Dr. Ian Hickie is visiting with colleagues here from Australia, and we're going to be treated to a presentation today that's I think highly relevant to the group that's here today. So Professor Hickie is a professor of psychiatry, co-director of health and policy at the Brain and Mind Center at the University of Sydney, as well as scientific advisor for Inowell Limited. He has led major public health and health services developments in Australia, particularly focused on early intervention for young people with depression, suicidal thoughts and behaviors, and complex mood disorders. He's active in the development through co-design, implementation, and continuous evaluation of health information and personal monitoring technologies in order to drive highly personalized and measurement-based care. Ian, thank you so much. Over to you.
Thank you so much, Ben. As some people know in my career, I'm a great bench player. When somebody pulls out, I'm always happy to fill in. In this case, my great friend Kathleen Merrick-Angus from the National Institute of Mental Health, who was due to be here, couldn't be here today due to something happening on the other side of the border here, causing some disturbance in people's lives. There's a great opportunity to be here, and I would like to start by paying my respects to the traditional owners of these lands, which have never been ceded. We have the same experience in Australia, of course, of the impacts of colonialisation, and our university, our Youth Mental Health Centre, sits on the lands of the Gadigal people of the Eora Nation, which has never been ceded, from which we have similar learnings in our own land. It's great to see that acknowledged in our collective countries. I'd also like to recognise Sunny's contribution and that of young people and their carers and families. It's always great to have David here, because I think often the carers and families are left out of that, and we need young people to share their experiences. I have some sympathy with Ben's opening comments about neglect of this area. And I take your chairman's challenge. It's up to us to do something about that on an ongoing basis. But there is a fundamental neglect in the research. And I must say to many of the young people here in this country and our own country, neglect in the provision of adequate services over time, services that really respond to the needs of young people with significant mood disorders, which have long been neglected in terms of their long-term outcomes. And I think the challenge for all of us, and the great pleasure of being here, is to share information, is to share common insights, and to try and build those national collaborations. I think the answer to the problem is having many young people join the area in terms of active research, work in partnership with young people with the disorders, and promote international collaboration to lift our game in these really challenging areas. If I get this to go forward. Going forward. Oops, went forward too quickly. That one should work. Okay. There are some disclosures just in terms of some of the technology I'm associated with and some of my other roles in this area. I mean, of course, it's fairly obvious to say for most of the major mental disorders, there's these peak ages of onset. And early intervention is, of course, all about being close to the onset and hopefully intervening in effective ways to do that.
I was looking at some national data in Australia just overnight. We have a very large genetic study of over 25,000 people with major mood disorders, including over 5,000 with bipolar disorder. And the bipolar disorder literature in Australia is equally challenging, that most people don't get a diagnosis till their early 30s. Most people have had an onset in their adolescence and have not received adequate care. And most worryingly, have been through our health systems over that long period of time. The challenge of early diagnosis, of moving into effective treatment to change the course of illness remains as much of a challenge in our country as it is in other countries. So all along, and led in Australia by my great friend Pat McGorry and others, but particularly in this area where I work with Jan Scott kind of internationally, of course we have the pipe dream. Could we identify people earlier and intervene effectively to change the course of illness? Now, for most, it's been a kind of pipe dream because early diagnosis is not simple. It's fine to say in retrospect what happened. It's not easy to say prospectively what will happen and to sort that out, and then to know whether intervening will actually change the course of illness in terms of changing the specific illness course or the consequence of illness over time. But it certainly is our goal. It remains our goal in a lot of the areas of youth mental health. Can we do that? Can we identify those who are at most risk of progression to a worse illness outcome from everybody else who may be distressed or have other sets of difficulties? And can we then effectively intervene in specific ways? As part of international networks, I just want to emphasise the international networks and why it's so good to be here. We're fortunate at the moment to have some work funded by the Wellcome Foundation to take this forward. And I just want to really emphasise the international nature of that and particularly highlight the work that Kathleen Merrikangas leads in terms of the transgenerational cohorts, in terms of cohorts she's working with, and work we have with Jan Scott and others internationally, looking at these particular sets of factors and trying to look across a range of areas. And I won't go into all these areas today, but in the genetics, in longitudinal studies, interventional studies, and in new biomarkers in the area. And one of the areas, it's a great pleasure to be here with Ben, is on the physical health consequences, what is really happening metabolically, physiologically, and to see bipolar disorder as less as a psychological condition in isolation and much, much more as a whole body condition that is having implications across the whole of a person's health throughout life, which has been relatively neglected. And just since Kathleen's not here, to emphasise the extent to which that international collaboration, particularly on the motor activity and energy activities, a lot of the work we're tied up with is seeing bipolar disorder much more in terms of its changes in motor activity and sleep-wake cycles, and less in terms of its mood changes, and monitoring that worldwide and collecting data worldwide. I think part of the solution, how to grow the area, is to get as much data from as many different settings in relevant cohorts over time, to combine the psychological work and a lot of the work that David was talking about. I'm so glad to see mentions of Ian Falloon and expressed emotion. I feel old enough to know about that. What I always thought was great about that work is that people with mood disorders were much more sensitive to expressed emotion than those with psychotic disorders, which was then largely ignored by the field in that kind of area, that the sensitivity of people with bipolar disorder to their psychological context was incredibly important. But also what is happening to them physiologically, the changes in their physiology and the relationship between the changes in their physiology and the changes in their interpersonal environment is critical to the course of the disorder. And Kathleen has really led that work to encourage international collaboration. Now, we have particular models of illness. We come at the situation a little differently in Australia. We're lucky to have a national network of early intervention centres for mental health in general to encourage young people to come into, which I'll talk about. So this allows us to bring people in with a whole range of mental health difficulties, not simply selecting for a particular mood disorder or a particular psychotic disorder or a particular depressive disorder. And we are seeking to intervene at earlier stages of illness as people are at that threshold. I was debating with my great friend Peter Zatmari here in the Kundal Centre, which I'm an international advisor to here at CAMH, about can we predict the onset of something? And he was being what I think called the appropriate skeptic. You know, predictive models are not easy. They're not very good in most of our areas, in psychosis and these areas. And I was saying to Peter, it's not so much about just predicting the outcome. It's a matter of being there while that outcome is happening. It's actually being engaged with people and tracking to people as you see that transition happening and intervening as it happens, not simply whether you can predict it. That requires having service models and clinical models that are actually engaged with young people during these particular periods. And that's really been our goal in Australia, to try and introduce notions like clinical staging and others to get with people earlier, to get with young people earlier and try and have them come into systems that would be with them through those periods and pick up as early as possible key transitions into things like bipolar disorder. Important to have also, it's great to have David here, about a longitudinal developmental perspective. What's really been happening in late childhood through to early adolescence, and not waiting as much as the bipolar literature does till someone's 20 or 25 or 30 and saying, oh, well, now it's clear. And you go back and say, well, actually, there have been difficulties. A lot of the work in this area around attention in children, associations with ADHD, associations with psychical difficulties, has largely been ignored by the adult field for a long time. And trying to understand what are those childhood phenotypes, what are those early adolescent phenotypes, what's happening during these critical hormonal changes in adolescence, and seeing those trajectories over time. So we have a model that tries to fit that in. What were the representations? What we would call the age-dependent phenotypes. How did those people look as kids? What happened during the transition through puberty? What's happening through adolescence? And how does the phenotype evolve over time? To do that, you've got to have a longitudinal perspective. You've got to have a way of actually tracking significant cohorts over time. So we have a model of care for these sets of mood disorders in younger people. And it's got a number of characteristics. One, are tech-enabled. You've got to collect data. David was just showing you've got to have data over time. Not just we'd say about mood, we'd say about sleep-wake cycles, about motor activity, and some of the issues that Ben's emphasised in his work, the physiology of that as well. What's happening immunometabolically over those periods of time. You've got to have a notion of staging. You've got to have a notion this doesn't just happen out of the blue. What were the earlier frameworks? What was happening earlier on at the earliest, as Dave was alluding to, subthreshold symptoms or prior symptoms? And at what point does that really become the thing that you could then call bipolar disorder? And how do we agree about that? Still much of great debate. And a notion of pathophysiological paths. Within this area, it's not all the same. There are people who've got different underlying pathophysiological mechanisms. We're pretty preoccupied with Kathleen and others with the circadian system, your 24-hour sleep-wake cycle, as being a big driver. Others are more occupied, as David just alluded to, with some aspects of metabolic systems, where there are energy-driving systems that may be changing those things. So we've got to also move our work to try to look at those physiological correlates of the different phenotypes that we are seeing. And to do all of that in the modern age, and this sounds like a funny thing, I'm sure, to people under the age of 25, to talk about being tech-enabled, you have to have data systems that stick with the same young person over time, that are shared with their clinical services. Just this week with CAMH, we've been discussing how you might change your systems here internally to track the same people over time in consistent ways. Now, particularly, I think one of the problems in bipolar disorder and mood disorders is the extent to which people have an on-off disorder. And of course, when the disorder gets better, we in services tend to say, go away, you don't need us anymore, until you come back again. And then we've lost track of what happened in the meantime. We've lost the continuity over time. One of the areas with psychosis, of course, worldwide, is the tendency for a lot of those younger people to have persistent disorders, so that services have to stay engaged with them while they're unwell. One of the tricks or challenges of the mood disorder area are their on-off natures and the loss of information over time, the loss of continuity. We think through modern technologies, it's much more possible to do that. David showed one EMA being really important, to be in contact with people, but encouraging the continuous collection of that data and the sharing of that data continuously with clinical systems, so that we respond in real time to the variations as people get unwell, not waiting till things have always got very unwell before we do anything subsequently. So we work with a particular pathophysiological model around these areas, which is very much focused on circadian systems. That's our particular preoccupation. What is it that circadian systems have genetically? How are they determined? We're all quite different in terms of our chronotypes, our 24-hour cycles, what environmental factors interact with that at different stages of development, how that gives rise to different phenotypes at different ages, how do we track those phenotypes? And of course, more importantly, what illness course does that result in? What are the specific treatments that would arise? And a lot of our research focuses on different aspects of that model. So when we're talking particularly about the circadian area within our general youth area, we're pretty much over on the right here. We're looking for the early phenotypes in terms of sleep-wake cycles, in terms of energy disturbance, in terms of other factors that come together, that concentrate down to put people at risk of that critical transition then into disorder over that part of the model. We're trying to intervene earlier. We're trying to pick people up at earlier stages. So at an individual level, treating each episode is easier if it's less severe and earlier, and then putting in place secondary prevention measures to try and make sure that the illness does not recur. Of course, what currently happens is people come late when things are already extended, when there already are complications, when there are already things like substance abuse, there's already social impairment, and trying to make it intrinsically more difficult to achieve a good outcome at that stage. It also matters in making these differentiations because treatments are different. So, of course, it matters, we would argue, in the bipolar area, in these major circadian type areas, that the treatments may be fundamentally different. I started my career in a lot of areas related to fatigue and persistent fatigue syndromes, and I loved it at the time because it was the one area in which SSRIs did not work. And in fact, in this area, a lot of the kids we see with these type disorders, SSRIs make them worse, not better. So the standard notion of seeing young people with depression who are presenting here, almost by definition, the groups we're interested in are those who do not respond or do worse when they're treated in a kind of standard non-specific way. And a lot of our work focuses on what would be better behavioural treatments, pharmacological treatments, chronotherapeutic treatments, things would focus on the sleep-wake cycle or focus on particular targets that would be more likely to work for this particular group. I think it remains one of the great challenges in psychiatry in general that one of the major mood disorders, bipolar depression, still does not have an effective treatment. And that we really need to focus on what would be the most effective treatments for that disorder, but particularly early in the course. And then, of course, preventing mania and preventing the recurrence of mania is critical. Now, as I say, we're lucky in Australia because we have had this outbreak, if you like, over the last 15 years of kind of national centres which are non-specific in their intake. They're not for bipolar disorder or eating disorders, psychotic disorders. They just encourage young people to come forward. There are now over 170 now of these centres in Australia. That encourages a lot of people to come in. Now, a lot of people come in and have a lot of different problems. Within that, trying to sort out who's more likely to go on to bipolar disorder or psychotic disorders or other specific disorders remains incredibly challenging. But it has given us a framework to work with in terms of longer-term longitudinal studies in this area. So at our own Brain and Mind Centre, my partner Elizabeth Scott, there over on the right, she runs the particular clinical program and associated with this. Headspace is the name of the program. It very much has youth focus on it. And we are, and if you like, on the left there, we're the kind of research centre sitting behind that trying to track what happens over time. And in our own particular centre over that particular period, we've had over 7,000 individuals come through that. When they present, they largely have non-specific anxiety and depressive disorders as the main presentation. So you see these non-specific type syndromes quite early in their course. However, within that, there are significant numbers of bipolar disorder, bipolar 1 and 2, and also of psychotic disorders. So while they're the minority at presentation, there are a significant number within that greater set that we're trying to identify. What we've been trying to do over time, of course, is identify who goes on to develop those disorders. And that's been really interesting. When we set these studies up, we assumed that numbers that would transmit would be relatively high. They haven't been as high as we thought they were. Sometimes when you expand the size of the funnel coming in, you get more and more people. You don't necessarily get more of the people who in the longer term are likely to proceed. So we're trying to capture people earlier, make it easier to come in, but that has a lot more people coming in. Trying to work out who is going to go on to receive disorder becomes actually quite difficult. And it's been very interesting in comparing those cases who already presented with new onset cases. And I think there are a number of learnings of this out of it in terms of our own work. Let's make some top line sort of comments here. One is, unfortunately, even though these are so-called early intervention services, the majority of kids who've got bipolar 1 already had it by the time we see them. So although we're setting up these services, the majority of people come forward between sort of 18 and 22 as the peak age of actually getting to these services, by which stage most of those who are going on to bipolar 1 already have it. So attempt to have early intervention services are already relatively late. Most of the new onsets after that are mainly in the bipolar 2 category. They're mainly in the unstable mood area, and that continues to be the case. So one of the learnings out of this is our so-called early intervention services are not early enough. We need to actually somehow shift that backwards. And it says a lot about our system, that people, even in a fairly open system, it's a nationally insured system, it's largely free to come in, come late and come after school when they've left school and their dysfunction is kind of obvious. They haven't continued with their life in the way they would have come forward at that time. Of course, when we see those young people, their parents, their families, others say, well, of course, we've had difficulties for quite a long time, but whatever help we received didn't put it in the kind of category that you're now putting it in. So shifting earlier is one of those sets of issues for us, but also having better ways of predicting what will happen is sort of critical. So what we are doing also in this work is comparing those who are on that bipolar trajectory with those who are on a more psychotic trajectory. So our work is quite different, if you like, in having positive controls, trying to sort out who's more likely to go in which direction over time from the general non-specific areas of anxiety and depression. So we've been able to track this type of trajectory over time. So lots of people come forward with early stages of anxiety and mood disorders. But then we can sort of track, well, where do they go? Who ends up in that group of what we call a circadian or bipolar spectrum over time? And by contrast, who goes over into the psychosis type spectrum? Now, interestingly, when you do allow a lot of people in with anxiety and depression, non-specifically, the majority of transitions that we see are over, in fact, into the circadian bipolar disorder over time. So some people stay in the same mood disorder area and just get worse in the same pathway, but you do see a significant number crossing over and their bipolar nature becoming more obvious over time if you're actually with them. So to pick up the criticism that Peter Zatmari was saying, I'd say our response to the criticism is you can't predict it, is you can find it if you stay with people. If you stick with them, you will find them and you'll see that transition happening over time. So not necessarily needing to have the best predictive tools in the world, but if you're actually sitting with people over time, you're likely to see the evolution of that. And then therefore the possibility of effective early intervention increases. Now in work led by Frank Iafino, who's in the audience here with us today, we've actually looked at these transitions over time in terms of prediction of who is more likely to go on from early stages of illness to later stages of illness. And it's interesting in that sort of set of issues, the issues of having had childhood disorders early as an important predictor. Psychotic-like experiences is a non-specific predictor. Psychotic-like experiences doesn't just predict psychosis. It's a severity predictor. It says actually anyone who has psychotic-like experiences early in their adolescence is likely to go on to a worse disorder. And importantly within our work, circadian-like disturbances, sleep-wake cycle disturbances is a strong predictor of progression over time. Now, of course, sleep-wake cycle factor is not important just a predictive factor. It's one you can intervene on. So David was raising the important issue about seeing the expressed emotion issues and family things. They're things you can intervene on. Some other things like the genetics you've got aren't so easy to intervene on, but sleep-wake cycles are something you can intervene on that are changing a lot during that area. So seeing it as an important predictor is an important way for us to sort of identify what may be worthy of intervention. So if we look at our new onset versus late onset type cases in this area, mania-like experiences, psychotic-like experiences are important predictors, but there are others. And I particularly want to take up the ones around self-harm and suicidal work. So again, in work led by Frank Iafino in our group, suicidal presentations are seen very often in our emergency departments, in our acute services, amongst young people, amongst young teenagers, and are often attributed to many other factors. And in our emergency departments are somewhat seen as a frustration, not really that important and just seen as a crisis kind of factor. But in fact, early presentations of suicidal ideation, suicidal behaviour in our work is actually a predictor of the later onset of bipolar disorder. And I think often skipped over and often attributed to other situational factors or other personality factors. And the possibility of it being an early reflection of bipolar disorder is often just skipped over or ignored. Importantly, within that, I just can't quite see that myself but the childhood disorders. So the childhood syndromes, this goes back to David's work and others. I think the extent to which earlier childhood syndromes are kind of being ignored in a lot of the adult work is important. So those kids who've had earlier onset of mood disorders in their late childhood years, early adolescence, is an important factor in our kind of work. And you see that more of trying to see that trajectory of what was happening pre-puberty, then extending into puberty. And a lot of the adult work, I think, fundamentally remains still largely ignored. The issue about family history is a really important one. Now, family history is a complicated thing. If you've got it, it really matters. Unfortunately, a lot of people in this syndrome don't have it, or it's not easily detected, or it's not easily known. Dad's substance abuse, dad's rage problems, dad's other difficulties are often not seen as necessarily the mood disorders. Mum's other difficulties not necessarily known. What happened to your grandfather, your uncle, and others isn't necessarily widely shared. So family history is a difficult thing in terms of its detection. Its relevance, if it's positive, is a strong predictor. But a lot of kids that we see, it's not obviously positive. And I'll come to later the importance there for polygenic scores and other factors we may have in the future to assist us in understanding genetic risk over time. So in terms of the things that really do matter in terms of the predictors, it's not surprising that mania-like experiences is a predictor. Now, this is also difficult in our adolescent work, and I'll show you some work from our Brisbane longitudinal study of twins. While mania-like experiences are a strong predictor of later bipolar onset, unfortunately, activation syndromes in teenagers are very common. So something has predictive value, but its specificity is somewhat limited because lots of teenagers. Other factors become important as well. So I want to just really emphasize the chart. Okay, all right. Okay. Oh yeah, we're back on. So Ben, how do I get back to so interesting.
Let's see. Is that right?
There we go. Yeah.
So we'll just get back started with Dr. Hickie's presentation. I think not too many people have left the room, so in the interest of time, we'll turn it right back over to him.
Thanks, Ben. So after that small introduction, I was just saying about what actually predicts the onset of mania specifically in our areas. So mania-like experiences being one of those factors, suicidality and childhood depression being another. And the factor I was just talking about when the alarms went off, lower functioning coming in, and lower functioning predicts for both for psychosis and for mania. And I think this does pick up the neurodevelopmental problems that we see in a range of kids. And I think it's been debated a lot in the bipolar disorder area to see bipolar disorder as not being related to cognitive difficulties or earlier brain development as much as psychosis. But in truth, there's a whole range of kids that do have developmental problems that are at risk of progression to illness over time. So just on the suicidality issue, this is really strong in our own longer-term literature. The kids have been presenting with suicidal behaviour, being at risk of the onset of bipolar disorder. So in terms of the longer-term outcomes in our particular cohorts, I think there are a number of particular key messages that a lot of the kids we see, as I say, already had it when they came over time, although we are seeing more kids go into bipolar type disorders, particularly bipolar 2, than psychotic disorder. And so although we've got a lot of kids with anxiety and mood disorders, it's not that easy to pick out the ones who are actually in risk of progression. And that, that's moved. And if we're going to really improve this issue, it raises an issue about enrichment strategies. And I think this is a real challenge for the field. We've got to get more people in, but also we've got to think about ways. Now, one is to do what David's been doing and others have done a lot of, which is include family history or do offspring studies, which is great for studying certain aspects of disorder, but only in those who've actually got the family history or the offspring. If you're trying to deal with the wider population set, it's more challenging. And so we've been really interested in what other ways of studying people over time, what other circadian features, what other polygenic risk score features, what other immune metabolic profiles that you could test in wider populations might actually be useful. And a lot of our work at the moment centers on those particular issues. So just on the metabolic bit, which I was really keen to include in this presentation and in Ben's hometown, if you like, is the extent to which we've been looking at insulin resistance over time. Now, there's the obvious association with BMI and insulin resistance, but we see a lot of kids earlier on who have insulin resistance who do not have increased BMIs over time. And they've got actually insulin resistance when we first see them, and they are not overweight. Now, they are at risk of becoming overweight as they progress over time and as they progress with treatment. But the insulin resistance factor, which I think has largely been ignored because people just measure glucose all the time. And of course, your glucose stays normal if you're producing insulin, at a particularly young age. But in fact, your insulin isn't normal. And we've been following that over time in our early intervention services. And it's particularly those with a circadian bipolar phenotype that have worsening insulin resistance over time in us. So very similar to what David was showing, over time, they're the group who get worse compared with those who have depression and have psychotic disorders more general. So for one reason or another, it does appear that the bipolar group is particularly at risk of that. And when we look at it compared with the psychotic disorders, they are the ones, so HOMA2 is the way of adjusting insulin resistance for existing glucose, the sort of measure of that. And they also have inflammatory factors. So the group of the neurodevelopmental does not tend to have CRP-related factors. So we see inflammatory factors and insulin resistance, particularly in that circadian group earlier on. Largely, I think, again, just ignored in the field as to whether this is actually characteristic of that particular group. So we're trying to incorporate that into a lot of our risk type statistics. We do have this general model that the thing that preoccupies us is the circadian factor and how does it present at different ages, and what would you see in childhood in terms of eating patterns, in terms of sleeping patterns, and then in the adolescent period, what do you tend to see? So we're interested in the kind of depression you see earlier on being much more atypical, much more associated with hypersomnia, with weight gain, with low energy states, rather than necessarily with sad mood states. And the extent to which in later adolescence, you're more likely to see the activation syndromes be more clearly hypomanic syndromes. And the risk factors to that genetically and environmentally develop over time. Underpinning it all is what's happening basically with your brain clock. What's the genetics of that? What's the regulation of that circadian system? And people will be aware that back in 2017, there was a Nobel Prize for actually revealing the circadian system and its mechanics in flies, the United States. Actually well worked out in humans these days and in other mammals as to how this actually works. Importantly, though, we can get insights into that by tracking motor activity, by tracking other factors in time. We have a model about what is actually going on in terms of motor energy and metabolic disturbances and the extent to which that flips in time. Really interesting in the bipolar area, not just what it is, but what's the switch? I mean, the most interesting thing in many ways about bipolar disorders and major mood disorders is their on-off nature. What is it that is unstable, that allows people to be in such a profoundly disturbed state, but then switch out of it again? And we know bits about that, like seasonality, light exposure, infection, the postnatal period, some of the triggers in the external environment that appear to affect that. Most of our work's tied up with what is that switch? Now, the most important switch we all have is the 24-hour one between the activity during the day and sleep at night. And our work is tied up with whether that same switch, of course, is the thing that's fundamentally very sensitive to instability in those with bipolar disorder. Now, these days, we have lots of ways of tracking that. And so a lot of our work with Kathleen and worldwide is not just the mood tracking that David was showing earlier on, which is really important, which the psychological state that accompanies it, but what is happening in terms of the motor state and the sleep-wake cycle. What is actually happening, and can you record that in individuals? Can you actually get the characteristic pattern, not just of the group, but of individuals as they move in their own systems and the nature of their instability? So with Kathleen, we've been part of these MMarch things using gene active watches to record these patterns, to unpick not just the sleep aspect, so not primarily a sleep disorder, but a sleep-wake cycle activity disorder and how it happens and its circadian periodicity. So this is out of Kathleen's NIH sets of studies and the extent to which you can differentiate different patterns in those with bipolar disorders from those with other common mood disorders. Really important to try and use that with modern statistical techniques to separate out those difficulties. And one of the really important things associated with Kathleen in studying this very important paper in JAMA Psychiatry, the extent to which activity and energy drive mood, not the other way around. So just think about that. Activity and energy driving mood in a subsequent period. What you're doing now, which is the worst thing possible, sitting doing nothing inside, tends to be associated with low mood in 4 hours' time. If you were to run outside and run around the block and be more active, your mood would be better. And the extent that it happens on a 4-hour period, but it happens on a 24-hour period and a continuing period. And really important kind of insight to the extent to which mood is often a consequence, not the cause of those changes in activity and energy. In our own work, we look at the delayed sleep phase. It's very characteristic of particularly the kids with bipolar disorder we see. In fact, a lot of them have become nocturnal. They're not very active during days. They're very active during the night and barely getting up during the daytime. And the extent to which, really importantly, not just is that happening on a 24-hour period, but the loss of rhythmicity, if I can say that correctly, not having really strong day-to-day patterns. So very easily perturbed out of a regular pattern by the environment in which they exist. So they've got an unstable pattern that is then further perturbed by instability in their environment. And in our work, that's not just a behavioural issue. There's a lot of discussion these days, of course, about the impact of new technologies, what's driving that on an ongoing basis. But the internal clocks rely on the release of melatonin when darkness comes on in the evening to help you to go to sleep. It's not a sleep hormone, it's a timing hormone, the timing of when you need to go to sleep and the regularity of that. What we find in kids with bipolar disorder and more severe disturbances is reduction in the melatonin signal and delay in its onset. So if you think about that, those kids are therefore likely to go to bed later and have greater instability. It's an internal factor. It's not being driven by the behaviour. It's an internal factor that's making it harder, in fact, to have a regular cycle on an ongoing basis. In work that Jan Scott's led and look at bipolar offspring, you see similar factors. That is a heritable factor that is driving, in part, the transmission of the disorder across generations. We've looked also at computational models. Now, I want to just dwell here a minute. Making up simulation models, running clinical trials, as David just showed, a whole career of clinical trials, is really hard. It's really intensive. It takes a really long period of time to try and look at a specific factor. An alternative or an adjunctive strategy these days is to use simulation models, is to build models of illness and then look at what factors might have the greatest factor on the outcome of that illness. So in work again that Frankie Affino in the audience has led, we've been looking at agent-based models of mania onset, the effect of seasonality, the effect of light, the effect of activity on driving mania onset. Now, when you do that and you take up all the factors that could be possible that we can monitor in terms of activity, the one that really stands out is reducing day-to-day variability. Now, this is good news and bad news for the young people in the audience. This is kind of like being boring, okay? This is actually maintaining a really regular sleep-wake cycle, day-to-day, weekdays, weekends, school periods, holiday periods, etc. Because the system in many young people is highly unstable. But the one big factor behaviourally that makes a really big difference to mania onset is to reduce the day-to-day variability. And the further you can reduce that, you can reduce, in these simulation models, the risk of onset. Now, in the work that we're doing, we continue to pursue this in prospective clinical cohorts. We're trying to look at the underlying physiology, what is happening in terms of melatonin, cortisol, orexin, and other factors that are happening over time, and the extent to which these factors internally have become dysregulated. Now, trying to fix that is really interesting. Pharmacologically, I'll discuss what we're trying to do with things like melatonin, but behaviourally, it also really matters. For those who, like myself, and I think others who might have dropped in, who are experiencing jet lag, we're down in this group at the moment. We're down in the group that actually has those things uncoupled. What you want to have is those that have really specific of behavioural and pharmacological interactions. So we're about to undertake a large melatonin type adjunctive therapy in stabilizer. If there is a problem with the melatonin system, then actually stay. Now, won't work on its own. It needs to go with a smart behavioural strategy to try and also increase regularity. Just finally, I want to mention the Brisbane longitudinal study of twins, which is different to our clinical studies in our clinics with my great friend Nick Martin over the last 30 years. This goes back like David. You've got to go back to 30 years ago when this started. Of picking kids up when they were 9, they're now in their 50s. It's like a really long-term study of what is happening with twins. But it gives us a whole lot of really interesting ways of looking at what are the key features that come together cross-sectionally and longitudinally. So issues related to energy, motor speed, and oversleeping are the key factors that condense together over time in those with bipolar disorder versus other mood disorders. Not primarily around the mood, but primarily around energy, psychomotor speed, and prolonged sleep. And basically what you see is that happening. Now, in our work with atypical depression, with weight gain, hypersomnia, we see the association with weight gain, with polygenic scores over time, and also with metabolic risk. So we're seeing a group in those earlier depressive phenotypes that also has this strong signal for metabolic risk associated with the circadian systems and poor response to therapy. So they don't do well with standard antidepressant therapies. So the work that we're associated with really tries to track early clinical phases of those moving from non-specific mood disturbance to bipolar disorder. Now, we think it is, in fact, tractable. It is an important issue to address, as you're trying to do here at CAMH and elsewhere. You've got to have clinical services that are there when they matter through these periods. We've traditionally not arranged services that way. And then we need to be with young people and their families during those periods and longitudinally track what is actually happening. We think with the combination of new technologies and multi-site collaboration, the potential to do that better is there, combined with new sorts of data science and modelling techniques. So I think it's a very exciting time for young people to be in the field if we can get more data. So to pick up Ben's earlier point, yeah, we need to do more research. The research needs to be smarter in terms of what it collects, not just the phenotypes, but the biomarkers and very much the personal sets of aspects. The variation is still large. From our point of view, optimising early clinical care for us focuses on their 24-hour sleep-wake cycle and the targets of that. And as I say, the principal focus for us is on reducing day-to-day variability, behaviourally and pharmacologically. Thanks for your attention.
I think we all admit that in addition to the impressive talk and research, that was impressive poise and rolling with it. So thank you for that, Ian. Unblinking. So we have, go ahead and take any questions from the audience, and I'll take an eye on the chat here.
Yeah.
Starting dosage at a low rate, titrating it upward. You're titrating the
Dose.
melatonin dosage upward as you see the results or the non-results of it.
Yes. Melatonin has this terrible thing. You know, it's not a proprietary product most places. Discuss with American colleagues, what do they think melatonin is? Well, they go down to their local CVS pharmacy and see what's being sold. And then they all go home and try it. You know, and sometimes it's called 2 milligrams, sometimes it's called 5, sometimes it's called 10. There's studies actually in the geriatric area using hundreds of milligrams. So it's a really big problem about the standardization. In our particular trials, we're compounding it ourselves and using 2 milligrams to start with, increasing to 4 milligrams, depending on the person's response to it. There is in Australia and elsewhere a proprietary brand that's a 2 milligram slow release form of the drug. Now, slow release is not what melatonin does physiologically. It has a short onset and then goes away. So that particular compound is made to resemble hypnotic drugs, sleep drugs, you know, to have a longer term effect to keep you asleep. That's not what melatonin does physiologically. So what we're trying to do is correct that graph that I showed you of shifting it earlier, regularly, and increasing the surge, and then doing that to create the timing. But the dosing issue is really hard because of the the very poor production of the thing. So unfortunately, this depends on where you get it from and then needing to experiment with people individually as to their sensitivity to that. Now, one of the things we did find in our earlier research is people think they can guess that from the behavioral aspects, whether kids going to sleep or staying up or not, and other aspects of what they're doing. What we found was there was actually not a very good correlation between a person's observed sleep pattern and their underlying melatonin. So in different set of work that I haven't shown, we're trying to develop point of care testing as to what your melatonin actually is. So that would guide both, are you one of the people who'd be likely to respond, and also whether the dose was driving the behavior. So it's one of the problems pharmacologically in the area is not working with a sort of proprietary product that's been consistently produced.
And one more question, is there an age where you look at starting that medication or depending on their symptomatology?
Well, there's two things going on. In the ADHD field, melatonin has been used forever. So kids have been taking melatonin for a long period of time with ADHD, which is interesting because there's cycle problems. There are attentional problems during the day, but there's sleep problems at night. So one thing to say is it appears to be relatively safe on an ongoing basis. So there doesn't seem to be a problem. So the issue for us is, when do we first see kids? And how early is that? So as I alluded to, we're trying to shift our work earlier. Now, what happens during adolescence normally is your sleep-wake cycle shifts to go to bed later. That's a normal developmental shift. So it's really the regularity we're trying to get, rather than saying what time do you go to bed necessarily, trying to make sure that is a reasonable period after the onset of dark, so before 11 o'clock at night, but trying to make it regular and trying to make it a 7-day a week, 30-day a month, not highly irregular, which is really difficult for adolescents given everything else that's going on in their world.
So, question from the online audience. What are your thoughts around parental guardian denial of mental health challenges in the moment and the late access of resources for individuals that are at risk for developing bipolar disorder? Any thoughts around parental education programs?
Well, I'm glad that David presented first. I mean, we have a lot of debate in youth services. Some youth services think that parents are always the problem. And a bit, I think, emphasised by the vignettes that David gave, the parents react to both the challenging behaviours of young people in this area, and they also, in my experience, react to the very poor response of services to their concerns. So in the monitoring technologies that Frank again leads, we have ways for parents to put in information, to be engaged. And often they've been told by services to go away, like you are, causing the problem. So we need parents, schools, others to recognise the abnormalities. And I think one of the things is to recognise also what runs in families, frankly, and the extent to which this may be a family problem. In my family, we have blue eyes, diabetes, and a liability of getting melanoma. As a consequence, we do all sorts of things because we know more about our family and our risk. In this area, we need to do more. Now, I didn't really go into detail, just for time's sake, about our polygenic risk score work, which we do with the University of Queensland and very large bipolar studies. I think in the future, we'll know more about how risk actually really runs in families. And in these enhanced services, we already have some early data, the extent to which polygenic scores are associated with healthcare seeking, with worse outcomes, and some specificity, some within that. It's interesting, the specificity is not just around bipolar risk, it's around ADHD risk and other sets of issues. So I think we'll come to understand better the genetic architecture. When we do that, I think the parental education, the sort of understanding of the biological underpinnings and the consequences of that on the social world. So Dave and I were just discussing, when I was very young, I was tied up with interpersonal therapies for depression and other areas. The consequences of mood disorders on the social environment is large. And the response of the social environment to those disturbances, to irritability, to changes in sleep, is also large. But a lot of work has moved into an individual cognitive model, which kind of ignores this. Whereas what we really need is to create environments that are quite structured and regular and predictable and probably low in their emotional expression to people who are particularly sensitive to that. If Kathleen were here, she'd talk about social anxiety and the sensitivity of people with bipolar disorder to criticism, their sensitivity to understanding what is going on in the social environment, but also their reaction to it. So I think the services thing is my biggest beef, is the lack of services that focus on this in the area and the early detection and the appropriate management, and that management needing to be highly personalised. So the parental education bit's critical, but I think also understanding what is happening within family systems, as David emphasised, and what's really happening across generations is also critical. So I think, unfortunately, I'm sure we'll hear about more of this during the day, it remains one of the most misunderstood areas of actually mental health and emotional disturbance during the adolescent period.
Great. We have another online question, this one on a different topic from Professor James Kennedy. For early intervention, are you considering measuring uncommon genetic mutations or copy number variants to find those at risk from this category of genetic impairment?
Yes, so I'm one of the, if you go to the most recent publication, Nature Genetics on bipolar disorder, I'm one of the 300 and something authors on that paper, somewhere down there. It has some key insights that it suggests people look at. One is the different genetic architecture of bipolar 1 versus bipolar 2, which is really interesting. So the first thing about that to say is the bipolar 2 bit shares genetics with depression much more than with mania. In Kathleen's work and in her family studies in the bipolar 1, this very large study that's just come out around the almost 300 variants, common variants that have been identified, then you see the bipolar 1 architecture is different and really playing on mania. So that's going to be really interesting. We may well see a separation. The second bit of that is there's then a bunch of copy number variation studies that are happening. And I think they're contributing to this neurodevelopmental diathesis that we see in a subpopulation. So I think that across the bipolar area and the psychosis area, what additional heritability can be put down to CNVs is being actively explored. Now, at the moment, the common variants and the CNVs don't explain a huge amount of the heritability. So we have some way to go, I think, in understanding whether in particular families or particular circumstances, CNVs play a larger role than others. But I do think the separation of genetic architecture in this most recent paper is really interesting. Whether putting bipolar 1 and bipolar 2 together all the time actually makes sense or it doesn't. They're fundamentally genetically different types of disorders that happen to share a depressive phenotype, but the mania motor activation phenotype is quite different and distinct and belongs really to the bipolar 1 category. No, you just got to, it's the whole psychiatric genetics consortia on bipolar disorder, just out in Nature Genetics. And this is really interesting because now finally there's almost 300 SNPs been identified. So it's up from 40 to 300. As a consequence, it'll give rise to a much better polygenic risk score or polygenic score than in the past. There's been some problems with the polygenic score that was first generated for bipolar disorder compared with schizophrenia and other areas. But I think that's about to dramatically improve.
Thank you again so much, Ian. I think we'll take actually a break now. And so we'll meet again at 11:05. So take a stretch, grab some coffee. Thank you. Okay, hope everybody had a good break. It's a little bit quieter. Hopefully it'll stay that way. I'm going to introduce our next and final keynote speaker. This is a great honor and a privilege to introduce my colleague, Andrea Vassilev. So I'll read you her bio in a moment, but first I'll just say that I crossed paths with Dr. Vassilev at ISBD in Chicago for the first time, and then we had opportunity to discuss the theme of patient and family engagement, co-production. I've learned a lot from her over the past couple of years. We co-chair what's called the Experts by Experience track of the International Society for Bipolar Disorder. So ISBD is, I think, relatively avant-garde in that regard in terms of bringing in to the scientific program. We're trying to get more people into the journal outputs as well, and to make sure that those affected most are included amongst the voices. But she's really, I think, a very rapidly rising and already well-established individual with lived experience of bipolar disorder, consumer advocacy, a clinician, as well as a researcher. So I think just a perfect fit for today, given our focus. So Dr. Vassilev is a clinician and academic who lives with bipolar disorder. She is the creator of the Overcoming Self-Stigma in Bipolar Disorder, the first program of its kind, which is now being implemented worldwide. Dr. Vassilev serves on the board of directors of the International Society for Bipolar Disorder. So she is one of two people for the first time ever that this is the case. And I think really a landmark transition in the society. And kudos to you for inspiring that type of inclusion. On their psychological interventions task force and as co-chair for their Experts by Experience committee, together with me. An award-winning advocate, Dr. Vassilev collaborates with major outlets across the globe to speak and write on her unique mix of clinical and personal expertise in an effort to increase knowledge and combat stigma, two missions that we can definitely get behind. Come on up.
Thank you for that kind introduction here. Let's see. Is that too high? All right, got it. Thank you for that kind introduction. I am delighted and honored to be here today. I'm going to address the important topic of self-stigma in bipolar from research, clinical, and lived experience perspectives. These are my financial disclosures from New Harbinger Publications, DBSA California, and the minimal sales of my group program materials. Some learning objectives. Hopefully by the end of this presentation, you will be able to define stigma and self-stigma, be familiar with the lived experience of self-stigma in youth and adults, examine research from the Overcoming Self-Stigma in Bipolar Disorder program, and apply strategies to combat self-stigma in your own work and daily life. Let's start with the basics. What is stigma? Stigma has become a bit of a buzzword these days in a lot of mental health spaces, and with good reason, as it is the start of a lot of problems. There's a great deal written about stigma academically, but we're interested in action here. So let's work with an actionable definition. Stigma refers to the negative beliefs held about a group of people due to a, whoopsies, sorry, I need help using this. Hold on a second. Can you help me for a second? If I want to scroll down over here, how can I do that? Okay, there we go. Sorry. Try again. Stigma refers to the negative beliefs held about a group of people due to a difference in them, such as having bipolar. For example, an example stigma, people with bipolar are unreliable and dangerous. So stigma is a negative stereotype. And one problem with stigma is that it kicks off a domino chain in human interactions. And we go from stigma eventually to things like discrimination, which are actions taken against a group because they're different. Then what is self-stigma? Okay. Self-stigma by extension refers to the negative beliefs someone holds about themselves due to a difference in them, such as having bipolar. So for example, because I have bipolar, which we've established I do, I am unreliable and dangerous. So just to review, stigma is the negative beliefs people hold about a group that is different, and self-stigma is when someone holds those beliefs about themselves because they are different. All right, we went pretty fast from one to the other, from stigma to self-stigma. How did we get there? So briefly, there are two theories as to how self-stigma develops. The first is the classic internalization model. This happens when people essentially pick up on or absorb stigmatizing beliefs held by the public. And over time, people begin to endorse these beliefs and apply them to themselves. For example, I've always heard that people with bipolar are unreliable. Now I have bipolar, or maybe I can't be counted on either. So it's kind of like toxic fumes. You absorb it and its negative consequences without even realizing it. The second theory is a theory that I've actually developed as a result of doing this work, and I'm drafting for publication, hopefully, the cognitive distortion model. So in this model, people interpret their very real experiences through the lens of cognitive distortions, which fosters negative beliefs about the self. Here's what happens. Life with bipolar is hard, right? People will have experiences that make them different from other people. And many of these experiences are in fact negative. If someone distorts these experiences by, say, overgeneralizing them into traits or overemphasizing or misinterpreting their importance, it can lead to negative beliefs about the self. For example, and this is a true story, I missed my best friend's bachelorette luncheon because I was having a really bad mixed episode. And I thought, wow, I'm really unreliable. I'm such a bad friend. So I distorted this single unfortunate event related to bipolar into a negative belief about myself associated with being different. So now we're back to self-stigma. So in all of the program groups that I've run, the internalization model, this classic model, has never explained 100% of the self-stigma people were experiencing, because people really do have negative experiences with bipolar. And thus was born the cognitive distortion model, which really resonated with people. There is complex interplay between these two systems, but that's the overview. That's the idea. Okay, that's all the academic type stuff. Why does this matter? Why is this so important? Why am I going to stand up here and talk to you about this for the next 30 minutes or so? So self-stigma across mental health conditions is associated with a host of negative outcomes in both adults and youth. So as you see here, we're looking at low self-esteem and shame and embarrassment and depression and poorer physical health, worse coping, worse treatment adherence. These are huge. Looking at the literature about self-stigma, specifically in bipolar, we're looking at three primary domains. This is all from adult research. There is a definite lack of literature about self-stigma in youth that is specific to bipolar. So as we were saying earlier, more research in this area. But there is also likely some generalizability. We'll talk about that in a moment. But as you see here, we're looking at impacts on quality of life. There's an inverse correlation with self-stigma and quality of life. Self-stigma may be a predictor of quality of life. It's associated with decreased functioning. We're looking at emotional well-being, so decreased self-esteem, decreased self-efficacy, but increased social anxiety. And health, here is the real kicker. With self-stigma, we're looking at poorer clinical outcomes, residual depressive symptoms, decreased treatment adherence and participation. It's correlated with increased hospitalizations. And there is very recent research showing that self-stigma in bipolar is actually correlated with increased suicidal ideation. So this is a fight for our well-being and for our lives. There are, theoretically, specific protective and risk factors for self-stigma in youth. There's the idea that, being young, teens have had less time and opportunity to be exposed to and therefore internalize public stigma. And this would mean, if you remember the two theories, this would mean that they would develop less self-stigma via the internalization model. However, teens are also highly sensitive to public perception. They may be more acutely aware of differences between themselves and their peers that are due to bipolar. If any teens with bipolar in the audience agree or disagree, just let me know. I'm seeing some stuff. Yeah, right? I've been there. Teens are also at a delicate time in identity development, so they may not have that strong sense of self that can be a protective factor against self-stigma. Now, combine all of this with teens possibly being more prone to cognitive distortions, and this may make teens more susceptible to developing self-stigma via the cognitive distortion model. So these are theories. We do need more research. But lastly, family perceptions of bipolar and mental health in general have been shown to influence a teen's experience of stigma. And that could be either a risk factor or a protective factor for a teen, depending on what the views are in that family. So great job, David, in psychoeducation. That can go a long way to preventing stigma as well. So again, more research is needed. Just for fun, this is me right around the time of my first episode at age 14. As you see, I look pretty happy, right? But I actually remember this moment. This was my fake it face. So for me, I was quite sensitive to the judgment of my peers because I knew that my experience was different from theirs, and thus the fake it face in an effort to fit in. But in the same breath, as an adult, I have no self-stigma, and I attribute this, among a couple of things, to the fact that because I was diagnosed so young at age 14, I never had an adult concept of myself without a mental health condition. There was nothing to reconcile. I had red hair, I had bipolar, it was kind of all the same. If you want to read more accounts of the youth experience of self-stigma, there are some wonderful narratives in CYBD's Youth Guide to Bipolar. I think it's really wonderful. They are quite meaningful. Check those out. So from all of these, I believe that interventions, therapeutic support for youth at this formative stage, as well as education about bipolar upon diagnosis, could be quite powerful in terms of mitigating self-stigma as a youth and later in life. So in my mind, an ounce of prevention is worth a pound of cure, or in Canada, I should say a gram of prevention is worth a kilogram of cure, something like that, right? Making the efforts here at CYBD truly critical. Let's consider a broader view of the lived experience of self-stigma. Living with self-stigma is like driving with the brake on. It makes everything harder. This is a quote from my friend, past president of DBSA California, but I'd like to share a composite vignette put together from the many stories I've heard about people's experiences. So let's talk about James. James is a 25-year-old teacher living with bipolar 1. Despite being stable for the past year, James views himself as fundamentally flawed. He tells himself, "I'm broken." James keeps his diagnosis a secret from friends. When others talk about weekend plans, he avoids joining in. If they knew, they'd never want to be my friend, he tells himself. During one episode, James was hospitalized and missed work. Upon his return, he couldn't face the thought of explaining to his coworkers what had happened. He thought, they'll never see me the same or trust me with the students. Instead, James left his job and found a new one in a different district. James ended a promising romantic relationship. As they grew closer, he panicked at the thought of disclosing his diagnosis. Rather than risk rejection for it, he pushed his partner away. They deserve someone normal, he reasoned. James was offered a leadership opportunity at work. What if I have another episode? They'll regret picking me, he told himself. Rather than risk failure, he stayed in his comfort zone, reinforcing the belief that his diagnosis made him less competent. It wasn't James's bipolar holding him back in different areas of his life. It was his self-stigma. I decided to address this problem. Overcoming self-stigma in bipolar disorder, or OSS-IBD, as I call it for short, actually started as the result of my doctoral dissertation years ago. Now, I like to joke that I'm the only person who files their dissertation and keeps working on it, graduates, keeps working on their dissertation, launches a career, keeps working on it, prepares for licensure, keeps working on it, et cetera, et cetera. But that is because I care about this issue and I believe in this program so strongly. So today, For the first time, I'm going to share the data we recently gathered to back up my belief in this work. All right, you say, what is overcoming self-stigma in bipolar disorder? Well, it is an 8-week small group program, ideally run with 8 to 10 people. It can be run with adults or adolescents. It's fully manualized, meaning that the facilitator need only follow the instructions that are given. There's no specific clinician training needed. It can be led by any mental health clinician who's worked in a group setting before. It should have the feel of group therapy meets peer group meets classroom. And it can be run in a number of settings or adapted for individual use. It's currently being used at private practices and clinics across the world, such as the Downton Center at Massachusetts General Hospital in Boston. They were one of the first to pilot the program. And there are current translations happening for studies in Japan, Greece, and Malaysia. In terms of who would be a good fit for the program, it's quite broad. As I said, it can be used with adults or adolescents, but participants should not currently be experiencing mania or psychosis, as some of the cognitive impairments in these states could make it difficult to do some of the thought restructuring work that's involved. People who are struggling with self-esteem issues, embarrassment, shame, withdrawal, all correlates of self-stigma would be a great fit. And it can be used with those who have a new or an established diagnosis. The content of the program, and you'll see the session titles listed here, is grounded in evidence-based practices for self-stigma that have been adapted to be specific to bipolar. And as we'll see in the qualitative data, this specification was actually considered a huge strength of the program. What do I mean by specific to bipolar? Well, start with the psychoeducation. The psychoeducation is all about bipolar, not just about mental health in general. The examples are about bipolar, so they resonate more deeply with people. And all of the other people in the group have bipolar. So in our study, I was surprised to find that many people had never even met someone else with bipolar. So that connection was actually very powerful. So condition-specific interventions may be more effective than general ones. The materials are comprised of 2 parts, just to give you an idea of how this works. The participants' workbook and the facilitator's manual. Like I mentioned, everything is provided in the materials. All a facilitator has to do is to follow the materials, which indicate what to tell the group, how to complete the activities, and what discussion questions to introduce and explore. The workbook and the manual function side by side. Neither can be used alone. And while the participants have just the workbook, the facilitator works from both. So it's much like a textbook with a student's book and a teacher's book. Both are digital as well as printable, so they can be used in person and also online, because I started this project before the pandemic. So user-friendly by design. For the workbook, every person receives a copy, again, printed or digital, and it contains all the information, exercises, writing prompts, at-home activities. It's graphically designed, so it's pretty engaging. And upon completion, people really enjoy looking back and reflecting, as well as reviewing the skills that they've learned. Here's an excerpt from the participants' workbook. This section focuses, as you see in the heading, on how to tell one's story. And it emphasizes the idea that the story of my bipolar disorder is not the story of my life. And if you're in this room and you're living with bipolar, I just want you to take a second and repeat that to yourself. So there's some talking points underneath that you'll see again in the manual in a moment. But these talking points include: a story is rarely all positive or all negative experiences, right? Your perspective on a story changes how you feel about it. You want to be truthful and highlight what's most meaningful to you. And of course, you want to allow space for hope. The manual, the facilitator's manual, includes the outline and the content to structure every session. It contains all the instructions that are needed to make the group happen. It also includes intro materials that the facilitator has to read to orient themselves. It includes a screener to identify participants who might benefit. And it includes an extensive list of cognitive reframes that can be used in select sessions. Again, facilitator uses them literally side by side. Here's an excerpt from the facilitator's manual. So this goes along with the excerpt we just saw in the workbook. These are the discussion questions that the facilitator introduces to cultivate conversation. I'll give you just a minute to look at these while I take a drink. So for each of those talking points, we see some discussion questions. Last year, about the trial we conducted in collaboration with Iowa State University's Self-Stigma Research Collaborative and Monash University in Australia, we ran a mixed methods RCT. So for the quantitative study, we had 403 adults assessed for eligibility and 137 randomized. And if you're like me, you're asking, what happened to those other 260 people who weren't randomized? Well, unfortunately, the ethics board gave us some very strict exclusion criteria since this was not done in a hospital or a treatment setting. They require participants to have no self-identified episodes in the last 2 months. And I think that many people took that to mean no symptoms in the last 2 months, so they were disqualified. But still, 137 randomized. We used a waitlist control, so everybody did receive the intervention in the end. 12 countries represented. I led the sessions online. There was no compensation provided. For the qualitative arm, 16 people completed 50-minute semi-structured interviews, and they were compensated for that. Our quantitative data, our primary outcomes were self-stigma, self-esteem, and depression, secondary life satisfaction, and help seeking. For self-stigma, we used the ISMI, but we used the 9-item version instead of the 29-item version because we did ask people to fill out a lot of surveys and we wanted to reduce survey burden. But now we don't have the subscales to analyze, so maybe next time. We use the Rosenberg scale for self-esteem, and we use the PHQ-8, which is, of course, the PHQ-9 without the suicide measure. Again, the ethics board had us do this for liability reasons. And we measured at the end of the 8-week program and at 1-month follow-up. Our first and primary measure was, of course, self-stigma. As you see, the group and time interaction was significant. So looking at the simple main effects for the treatment group in blue, we did see a significantly lower level of self-stigma post-intervention than in the control group in orange, where levels of self-stigma remained largely the same. And this was with a large effect size. And even at 1-month follow-up, the treatment group still scored significantly lower than the control group, though only with a moderate effect size at 1 month. Just as important as self-stigma, in my opinion, is self-esteem. So we found significantly higher levels of self-esteem in the treatment group than in the control group at the end of the program, with an even bigger effect size than we saw in self-stigma. And at 1-month follow-up, we saw maintenance of that significant difference, but with a moderate effect size. For depression, the group time interaction was significant, and we saw significantly less depression after the program with a moderate effect size, but this difference was not significant at 1-month follow-up. And there can be a great deal of variation in bipolar moods due to factors that are obviously difficult to control for. Similar to the results for depression, the group time interaction for life satisfaction was significant. And we saw higher life satisfaction that was significant at post-intervention with a moderate effect size. But this difference, again, same as depression, was not significant at 1-month follow-up. Lastly, we looked at the self-stigma of seeking help. Because the group time interaction was not significant, we did not test simple main effects. As you see, there is a floor effect happening here, which makes sense. These people volunteered to partake in this 8-week study with no incentive, just with the motivation to receive help. So their self-stigma of seeking help started quite low and couldn't really get much lower. But in self-stigma, we do see a lot of delays to seeking help. So for people who maybe were compensated, the results might have looked different. Here's a summary table of all the quantitative data at post-intervention and at 1-month follow-up. The measure that was most impacted was self-esteem, with significant improvements at both post-intervention and follow-up, with the largest effect sizes of all our data. Self-stigma was almost as impacted, so great results on our first two measures, and good, though not lasting, results for depression and life satisfaction. For the qualitative arm of the study, they used a reflective thematic analysis with an inductive approach. Qualitative results revealed a number of strengths of the program. For example, the content and strategies being specific to bipolar, which we know most therapy is not. That was a great strength. The group setting, like we talked about, provided connection to, exposure to peers, and participants engaged with others and felt less alone. I have one group that became such good friends that they're actually still doing monthly Zoom calls together just to catch up and be friends. It's really lovely. People felt prepared to make practical changes, such as regarding disclosure. In terms of limitations, one or two people who did the qualitative interviews struggled with reframing. So the program employs the CBT skill of cognitive restructuring for self-stigmatizing thoughts. And some people struggled with this because they felt that the reframes sometimes eclipsed their actual negative experiences. There is data still under analysis, including the mediators that explain the mechanisms driving these changes: self-compassion, self-coldness, external and internal shame. So we'll see how those come back. And there are, of course, limitations to the study, as with any study. The biggest one is likely to be generalizability. As we mentioned, we had some limiting exclusion criteria. So these data only reflect the impact of this program on those who have not experienced a lot of symptoms recently. Also, since this study was not incentivized, there was a level of self-selection that, again, may impact generalizability. We also did not screen our participants with a diagnostic screener. They had to report that they had received a diagnosis of bipolar. Not that they thought they had bipolar, but that they had actually received a diagnosis. Similarly, we did not assess or account for comorbidities. Lastly, we had some attrition. It turns out that people with higher baseline depression were less likely to complete the program, which is both interesting and makes some sense. Luckily, the amazing statistician who I worked with did manage to account for this, so we could still get a clear view of the data. Further research. Who would like to run another research study? Yes, I'm looking at you. I'm also looking at you, right? Most importantly, I want to see a study done specifically with youth. In that vein, a colleague of mine is working with the National Network of Depression Centers in the US and is hoping to run an adolescent trial, which would just be so wonderful. A very recent meta-analysis actually showed that stigma interventions are effective in youth in the short term, but there's very little written about longitudinal impact. So again, I would want to design adolescent trials to gather data on that. There's further research needed all around. We need greater longitudinal data with longer follow-ups. I want to see additional outcome measures, including relapse prevention and treatment adherence. Those are big ones. And it's important to investigate how impactful the program is when it's run by other facilitators, not just me. In any of these, I would want to use the full version of the self-stigma scale, which again is longer, but gives you subscales to analyze. So lastly, possibly through qualitative research, I'd be interested to isolate which factors of the program are most impactful, or is it truly the synergy? Other future directions, as I mentioned, there are upcoming trials in Japanese, Greek, and Malay. There is a New Harbinger workbook due out in 2026. So New Harbinger is a US-based publisher of psychology workbooks. And I am adapting the program into a self-guided version in order to reach more people. So right now you can only take the program if you're part of a center that's running it or you took part in this study. And some people, interestingly, expressed interest in this study, but were too embarrassed to be part of a program that was about having bipolar, which means they really needed to take the program. So hopefully the individual workbook will reach many of these people. You can sign up for updates about studies and the workbook and other developments at the website. So let's follow up with James. Give me a second. James's self-stigma kept him trapped in avoidance, self-doubt, and loneliness. But in moments of clarity, he wondered, what if I'm not as broken as I think? What if I'm worthy despite or even because of bipolar? With the help of targeted interventions and peer connection, James is slowly learning to challenge these beliefs. He's practicing self-compassion, reminding himself that his diagnosis does not define him. Step by step, he's reclaiming his sense of self. So what can you do to combat self-stigma in your patients if you're a clinician or in your community on a daily basis? First of all, if you're a clinician, consider introducing the program. I'd be happy to meet and see how it might be a good fit and you could work with it. Secondly, something I encourage all providers and people to do is to mind their language. So please, I ask, do not refer to people by their diagnoses. People have bipolar, they are not bipolar. You don't say I am cancer, you say I have cancer. There is research showing that person-first language, so I have bipolar instead of I am bipolar, reduces stigma in mental health. However, I need to say, disclaimer, there is some debate in the lived experience community of bipolar because a small group of people does prefer I am bipolar. But that is their choice to make, not necessarily yours. I also encourage providers and individuals to say, experiencing mania, depression, or psychosis, instead of manic, depressed, or psychotic. Remember, these are not traits, these are states. So with language, we can create distance from them in order to cultivate feelings of hope for recovery. And I know change takes time, but just put these in your back pocket somewhere and think about them. The last one, if you are a clinician, examine your personal biases. So do your inherent biases possibly contribute to public stigma? So provider stigma creates delays in diagnosis, in treatment, and in wellness, and therefore creates worse outcomes. I have a friend with bipolar, who was once told by a psychiatrist, you can't possibly have bipolar because you have a job. So imagine not only the confusion and the embarrassment, but the delays in treatment and the self-stigma that this fostered for this person because the provider had their own stigma. So please consider that. This trial would not have been possible without the support and the hard work of the whole research team. Just a quick shout to them. Both Ms. Zhao and Ms. Wormington are students who did absolutely fantastic jobs. Ms. Zhao in particular is a brilliant statistician, and I am so grateful to have worked with her. And Dr. Vogel and Dr. Morton are, of course, wonderful veteran researchers in this area. I want to express my deep thanks to Dr. Goldstein, the wonderful staff here, Dr. Dimmick and Golda, who have been such help to me. I also want to express my sincere thanks to basically every professor and clinician and researcher and peer leader and everybody else whose ear I have talked off about this problem and this program since I started in 2018. Thank you so much. Please feel free to reach out or visit the website to connect further. I look forward to it. Thank you.
Thanks so much, Andrea. That was just absolutely fantastic. We'll give people online the first kick at the can. So how do you separate out the effect of shared environmental exposures as opposed, this might have been someone before. Go to the next one. How would you control for, pardon me, how would you control for participant bias and a waitlist control for another self-stigma study?
How would I control for bias? And oh boy, I feel like I should have my statistician here with me. To control for biases to people who, well, I mean, that is a valid point to make. People who have waited around to take the program and to have the intervention are likely very dedicated. We actually didn't see a lot of fall off there. The most fall off, the most attrition we had was with the people who were experiencing more depression at baseline. So I'm not sure how I would control for that, but it is a really good point to consider.
I'll take one. So it was really interesting to me that some of the strongest findings were for self-esteem and that persisted despite people getting more depressed over the course of the trial. And I was wondering, like, if you've thought about that or what you make of the ability to maintain the therapy-related self-esteem improvements despite the depression creeping in.
Well, I think it's one of those, like I say to a lot of my clients, both things can be true, right? Depression will certainly have an impact on self-esteem, but you can be experiencing depression and not be feeling terrible about the fact that you were experiencing depression. Like, that's a very sort of beautiful, nuanced area in which you have your symptoms, but you know that they don't define you. And that's kind of the sweet spot, I think.
Good questions from the audience?
Yeah, Andrea, it's such an important area, I think, in the early intervention area. You made a comment at the end about shifting from a group environment to potentially scalable individual kind of things. I just wonder if you could elaborate further. I guess we often wonder whether the effect would be maintained. The effect of the group environment is so strong for many things. And I think we often in mental health abandon group-based things that work in an attempt to scale individually or digitally. Do you expect it to be as effective when you lose the group context?
It's a very interesting question. So I am hopeful. So the individual version you're talking about is the workbook that I'm publishing. And there won't be a way to test the impacts of that. I'm hoping with the marketing team at New Harbinger to do something that encourages people to do this in a group, actually inspired by one of my clients who does another bipolar workbook with friends of hers who have bipolar. So I'm hoping to do it on sort of an informal level, but I'm also hoping in the last chapter of the book to launch people into action in terms of seeking out peer connection in other places. So hopefully it will take them past that hurdle of having so much self-stigma that they don't want to connect with others to then connecting with others. So maybe it'll be a kind of a bridge.
Thank you for the presentation. I was wondering if you identified how to navigate associative or vicarious stigma, self-stigma within the family structure. That's a really important point that, as we saw, especially in youth, that the perception of mental health conditions and the perception of bipolar will impact someone's experience of stigma and their own self-stigma. So there is stigma by association. It's kind of a separate issue, but it is a very large issue because you see it cross-culturally, really, where families have such stigma about a condition that it really seeps into the person experiencing it. So that sounds like another doctoral dissertation that maybe I should look into. Thank you.
Here's one more. Thank you, run across. Hi, yeah, that was a great presentation. Thank you so much for sharing, and it seems like a really cool program. I was just curious about the finding you had about cognitive reframing. I was wondering if you could expand on why that was an issue for people with bipolar.
Yes, so for most people it wasn't, but for one or two people they were, and I actually, because I ran the study, wasn't double blind, I know these people were, and they were really acutely experiencing a lot of symptoms and a lot of regret about very recent events. And I think that they struggled trying to find, not a silver lining, but trying to spin something in a more neutral or positive sense because they were still grieving. And there is grief. And I know in individual therapy, we talk a lot about, grief of the loss of the healthy self, grief of things you've lost. And it may have been that it was just sort of a stage thing and they weren't really at a place, which I completely understand, where they could move from grief into reframing.
Hi, that was awesome. I have a question. Between bipolar 1 and bipolar 2, do you think there's a difference in the stigma that people experience?
Interesting. So I don't want to speak out of turn without looking back through the research. What I think that it depends in the cognitive distortion model anyway, largely on your experiences. So when I ran these groups, I found that the cognitive distortion model resonated a lot more with people who had had acute manic or psychotic episodes, who had really, done things that perhaps they regretted, that they felt embarrassed by, things like that. So that really stood out. But at the same time, the label of bipolar for someone who experiences mostly depression will come with a lot of public stigma attached to it.
Thank you.
We have a question from online from Andrea. Fantastic presentation and work. Thank you. From your experience and engagement with the community, what terminology is generally preferred? Is it people living with bipolar disorder or patients with bipolar disorder? Is there a consensus or preference within the community regarding this language?
So there's no consensus. I can tell you that. There's much discussion had on a lot of message boards, etc. Most people default to I am bipolar because it's what they've heard, which is why when I point it out, they say, oh, wow, that feels really different. I'm going to do that now. There is a small group of people I find generally who have less self-stigma, who prefer to say I am bipolar because they've truly integrated it into their identity and it's not really an issue for them, the self-stigma. Patient, I have one friend with bipolar who really objects to the use of the word patient. I use the word patient in clinical settings, just as shorthand, it makes sense in a medical context, in a psychological context. So there's no consensus, but people generally seem to really enjoy I have bipolar once they've introduced that because it gives them some distance.
That was, I don't know, awesome. So you mentioned that you're going to publish the actual patients guidebook. I'm just wondering, I guess I don't really know, how do you think the results of the actual program and study will change compared to in a controlled environment where, well, yeah, in a controlled environment compared to maybe outside of the actual study, if you can actually do that, because I know you wouldn't probably be able to gather the data from the individuals, but I just wonder if you have any idea of what could possibly change if there is a change.
Sure. So I think that you lose some of the fidelity of a program or of a protocol when you expand it for individual use. New Harbinger, the publisher, makes a lot of psychology workbooks with different skills for social anxiety, for CBT, for DBT, and that's not the same as doing them with a therapist, right? You lose some of that one-on-one, you lose some of that personalization, but the benefit is that you can reach so many more people, right? So there's a balance there, there's a trade-off. So you will lose some of the fidelity, people will have their own interpretations of what's in the workbook, but hopefully the benefit is that it will reach so many more people.
So this is an online question from Jillian Sedon. I can see how self-stigma is very important to address. However, I was wondering if you had any information on how someone's insight would impact their awareness of even acknowledging their diagnosis. My understanding is that insight is very difficult for individuals experiencing episodes.
Yes, so that's one of the things that I mentioned is if someone's experiencing acute mania or acute psychosis, they probably wouldn't benefit from the program because you do need that insight. You need to be able to do some of the cognitive work, some of the big picture thinking about your life and about your story and about your own perceptions and your own interpretations. So yes, insight is very important, and that's perhaps a limitation that we can't reach everybody at all times.
David.
Thanks, Andrea. Just wondered if you'd ever run across the excessively positive self-stigma, such as the, kind of Kanye West bipolar disorder is my superpower, or I'm super creative because I have this disorder. And what do you do with that? Or have you run across it?
So true story, in an earlier version of the materials, I have this list of famous people with bipolar that we talk about, and he was on the list, and then I took him off the list because didn't want him in my club. So anyway, I have not actually. I have not. What I run into is people constantly feeling as though they're not enough, and there's part of the program that talks about what are your strengths as a result of bipolar? Not that we're trying to gloss over or sugarcoat anything, but just, okay, here's a cloud. Can we find the silver lining? That's really impactful with people, but I have yet to have someone who is really like, yay, I have bipolar. This is great.
So we have another online question from Jeanette. And I'm going to add to it because I think it's an interesting question. Have you ever considered developing an online/technological/app component to go along with the workbook to increase the fidelity of the program? And my question to add on to that is, what about peer delivery?
So I would love a technological component. I had not considered that. Thank you to that person. Very interesting. And parts of it could be integrated possibly into apps that already exist. The peer delivery I have considered and I have tried, and it didn't totally work. So I trained some because I figured they would need training. I trained some of DBSAs, that's the Depression and Bipolar Support Alliance. It's the #1 peer group provider in the US. Some of their best facilitators to run the program, and some of them did. And we ran into some struggles where I have seen there's just some stuff that's clinical and it was hard to deliver. Where I have seen it work is that at Massachusetts General Hospital, they have a psychologist and their peer support specialists lead it together. And I think that is one of the best ways you could do it. So the psychologist can take on the clinical stuff, the peer support specialist can be that access point that makes it very personal and very meaningful. So that's a really interesting way to deliver it.
I just want to say thank you to you for this extremely thought-provoking and impactful and I think inspiring presentation.
Thank you so much, everybody. Thank you.
And we had 3 great keynotes, so thank you to all of